Good morning. We will have a short discussion about an impaction. Impaction, which is nothing but a pathological situation where a tooth fails to attain its normal functional position. So the tooth will not be in the occlusion. There are various definitions which has been given by the various authors for the impactions, which includes Round's definitions, Archer, Anderson, and the Peterson. Among the four authors, the most commonly used definition for the impaction will be the definition which is given by the Archer, which states that a tooth which is completely or partially unerupted beyond its chronological age and its position against another tooth, bone, soft tissue, so that the further eruption is not possible for that teeth. It is in a order of the frequency order how the impacted teeth will be. The most commonly impacted tooth will be the mandibular third molars, and the least commonly impacted tooth will be the maxillary lateral incisors, followed by the third molars, the maxillary third molar, maxillary canine, mandibular premolar, maxillary premolar, mandibular canine, and the maxillary central incisor, and the last, the maxillary lateral incisor. Coming to the theories of the impactions, various theories are there to define the impactions and how the impaction has been occurred, which includes an orthodontic theory, which states that the jaw usually develops in the downward and in a forward direction. Whenever there is any interferences which occurs for the growth of the jaw, which will result in the impaction. And then phylogenetic theory, which states that whenever the more functional masticatory force, better the development of the jaw. So the nature which is tries to eliminate the organ which is not used. So due to the changing in the nutrition habits, the use of the powerful jaws have been eliminated, and thus over the centuries, the maxilla and the mandible will get decreased in size, leaving an insufficient space for the third molars. Coming to the pathological theory, something which is opposite to that of a physiology. So it may be due to the infections or inflammation induced. Infections, as a result of a chronic infections, there will occur in a condensation of osseous tissues, which will further prevent the growth and the development of the jaws. Coming to the Mendelian theory, where he states that hereditary plays a very important role for the tooth to be get impacted. This because the individual will use to get a small jaw and the larger teeth from the parents. This may be an important etiological factors in the occurrence of the impaction. The last theory is the endocrinal theory. Endocrine, something is related to the hormones. Whenever there is an increase or a decrease in the growth hormone secretions, which in turn affect the size of the jaws, which will result in the reduced space for the third molar to get erupted into these function positions. As a result, impaction will occur. What is the cause behind the impaction? It may be a local cause or it may be a systemic cause. Local, which follows an obstructions, lack of a space, ankylosis, retained tooth, non-absorbing bone, ectopic position of teeth, dilaceration of roots, soft tissue or bony lesions, or an habit. Systemic causes, it may be a prenatal, which may be an hereditary, or maybe a postnatal due to certain infections, or maybe a congenital syphilis, anemia, and the malnutrition. Endocrinal, as I told you, due to the increase or decrease in the secretion of growth hormone. The rare causes will be an cleidoclinial disorders, osteopetrosis, achondroplasia, cleft lip, and the palate. And when to do an removal of extraction, removal of the impacted tooth, and when not to do an removal of impacted tooth. So there are certain indications and the contraindications. Indications, first and the most common indication is that whenever the patient present to us with a recurrent pericoronitis, if the patient is present with more than 2 times of a recurrent pericoronitis, the absolute solution for the pericoronitis will be the removal of that impacted tooth. So pericoronitis, which is nothing but there is an inflammation of the soft tissues surrounding the impacted tooth and the tooth in the line of the fracture. The tooth which is present in the line of the fracture will sometimes interfere with the reduction of that fracture bone. In such a cases, the tooth has to be removed, and the deep periodontal pocket or prior to that of an orthodontic treatment in order to provide a sufficient space for the movement of the tooth and the prevention of root resorptions and the caries or a retained deciduous teeth and management of the cyst and the tumors associated with that impacted tooth and the management of pre-prosthetic concerns, and the prophylactic removal in case of a patient who is going for the orthodontic surgeries. And the contraindications, extremes of the age. So as the age increases, the bone will become more sclerotic. As a result, impacted tooth removal will become more difficult. In such a cases, it's better to avoid the removal. Or a compromised medical status, excessive risk of damage to the adjacent structures, or whenever there is a question about the future status of the second molar. So uncontrolled active pericorneal infections, socioeconomic status, fracture of atrophic mandible, and abutment selection. There are various classifications are there for the mandibular third molars and for the maxillary impacted third molars. For mandibular third molars, it has been given by Winters in the year of 1929, Pell and Grigory in the year of 1933. Winter, who gave the classifications based on the angulations, where we have to draw a straight line along the long axis of the second molar and the third molar. If the straight line which has been drawn along the long axis of second molar and third molar which meet at the top, it indicates that impacted tooth will be a mesioangular. If it is meets at the bottom, it will be a distoangular. If it is meet at the right angle, it will be an horizontal. If it is a parallel, it will be a vertical. So coming to Pell and the Grigory, who gave the classification in the year 1933 based on the depth. Depth. It has been classified into level A, B, C. A, the highest position of the tooth is on the level or with or above the level of the occlusal line. You can able to see this diagram where the highest position of the tooth is on the level of the occlusal line. So in the level B, the highest position of the tooth will be below the occlusal line and the above the cervical line. In the level C, the way the highest position of the tooth will be below the occlusal and the below the cervical line. Coming into the space availability. Availability space between the second molar, the distal aspect of second molar, and then ascending border of ramus of the mandible. So if there is a sufficient amount of the space is present, the molar can get erupted, so it will not get impacted. So in such a cases, it has been classified into class 1. If it is a class 2, where the space available between the anterior border of the ramus and the distal side of the second molar is lesser than the mesio-distal width of the crown of the third molars. The third, class 3, where the third molar will be completely embedded in the bone from the ascending ramus because of the absolute lack of the space. This is the classification for the mandibular third molar. Coming back into the maxillary third molars. It is also the classified based on this angulation, which is as same as that of the mandibular third molars, where it has been classified into vertical, mesioangular, horizontal, distoangular, and if it is buccoverted or palatoverted or lingoverted and inverted, based on the occlusal plane, where it has been classified into class A, B, and C, and based on the relation to the sinus. So sinus is the most important structure which is present in the maxilla. So whenever there is a sufficient space which is present between the sinus floor and the impactor maxillary third molar, so it indicates there is no sinus approximation. If the space which is presented between the maxillary third molar, I mean maxillary impacted teeth and the sinus floor, if there is no sufficient space, so it indicates that the sinus approximation. So the third molar is just more nearer to the sinus. So coming into the difficulty index. So that this indicates that there are certain difficulties are there for the removal of that impacted tooth. So the treatment plan will always follow these difficulty index. So which has been given by the Pedersen in the year of 1988, Parent and the Winters-Warline. Pedersen, where you have been given the class difficulty index based on the spatial relationship, depth, and the ramus. So where the difficulty level will be classified into very difficult, moderate difficult, and the minimally difficult. For an example, if a patient comes to us with a mesioangular, as I told, level A, which indicates that the highest point of the tooth will be at the level of the occlusal plane. And the patient comes to us with a class 1, which indicates that there is a sufficient amount of space which is present between the distal aspect of second molar and the anterior border of the ascending ramus. So which follows? So the mesioangular is number 1 and the level A is number 1 and then class 1 is number 1. So we have to add all these 3 scores. So number 1 plus 1 plus 1, which indicates the total score will be 3. So the difficulty level will be minimally difficult. So it indicates that 3 to 4 will be minimally difficult. So it means that the removal of that impacted tooth will be easier compared to that of the distriangular or horizontal or level C or a class 3. So parent scale, where the difficulty is just based upon the extraction types. Whenever the extraction is which has been done, which is with help of the forceps, it is indicated as an easy extraction, or osteotomy, it is easy too. And then osteotomy and the corneal sectioning, which is based on the difficulty index 3, and the roots, whenever the impaction tooth removal requires sectioning of the root, it follows the difficulty index 4. And coming to the Winter's bar line. So Winter's line or the VAR line. VAR line is the most important for the impacted tooth, which will be traced with help of the IOPA, which means that intraoral radiograph, perioptical radiograph. So which is with the help of IOPA, we can able to trace these VAR lines. So VAR line, W stands for the white line, A stands for the amber line, and then R stands for the red line. White line, which indicates that differences in the occlusal line, whereas amber lines, which indicates that the alveolar bone covering the amount of alveolar bone covering the impacted tooth. The red line, which indicates red line. Red line indicates the depth of the tooth in the bone. So we have to measure the red line, which has to be drawn perpendicular to that of the line which has been drawn along the occlusal level. So whenever we have to measure the red line, so if the red line, which is more than a 5 mm, it indicates that the extraction is very difficult. So for every additional 1 mm, for example, if the red line measurement is 6 mm, so additional 1 mm of more than a 5 mm, so the difficulty index will be increased by 3 times. So it indicates that whenever it's that the red line is more than a 9 mm, the extraction has to be done under the general anesthesia, not under the local anesthesia. So coming to the another assessment, which is like WAFI assessment, where we have to do an assessment in the panoramic radiograph, which is panoramic view, which is nothing but an OPG, orthopantomograph, which is will be used for the tracing this WAFI's assessment. WARFI assessment. W stands for the Winters classifications, H will stands for the height of the mandible, A will be the angulation of third molar, R will be the root shape, F will be the follicle size, P will be the path of the exit. Each one will have the difficulty scores. So based on that, the difficulty index will be increased. So Winter, for example, if it is an horizontal and then height of the main mandible is 1 to 30 mm, or the angulations of the third molar is 1 to 59 degree, or a root shape which is a complex one, or a follicular size is a normal, or a path of the exit is that the space available, or a distal cusp is covered, or a mesial cusp is covered, or both the distal and the mesial cusp is covered. So that based on that position and based on that millimeter space, height of the mandible, based on the angulations, shape, and the size of the follicle surrounding the impacted teeth, and based on the path of the exit, the difficulty score will get vary. So coming to that, there is another most important things. If we are going to deal with a mandibular third molar, one should keep in mind that how far the third molar is from the inferior alveolar canal, since the most important nerve structure which is passes through the mandibular bone. So which has this depends upon the relationship to the inferior alveolar canal. The Poynton, who gave the classifications in the year of 1960, where he related to the root and the relation to that of the nerve. So always the classifications coming to the relation to root. Whenever there is a darkening of the root, or a deflection of the root, or a narrowing of the root, or a dark bifid root apex. Coming into the relation to the canal. So relation to the canal, where there is an interpretation of white line of canal, diversion of the canal, or the narrowing of the canal. This is the pictorial representation of the Poyntons, the relationship of the root to the inferior alveolar canal. Here you can able to see the darkening of the root, and here you can able to see the deflection of the root, and this is the narrowing of the root, and this is the dark bifid apex. And the relation to the canal, you can able to see the interpretation of the white line of the canal, where the impacted teeth is get interfering the white line of the canal, and the diversion of the canal and the narrowing of the canal. Coming to the most important, the surgical part. This first step will follows the IANB. So inferior alveolar nerve block has to be given to the patients and followed by the incision. Incision, which always will depends upon the depth of the impacted teeth. There are several principles for the flap designs. The most important will be the base of the flap. It should be always broader than that of a free margin to preserve the adequate blood supply. And then the flap should have an adequate size and it should be a full thickness mucoperiosteal flap. It should be made over the intact bone and it should avoid an injury to an local vital structures. It should always place away from that of a lingual aspect of the mandible in order to preserve the damage to the lingual nerve. There are various type of flap, which includes L-shape, bayonet, envelope, triangular, comma shape, and the ward incision. And then one incision is the ward incision, which is the most commonly used incision for the impacted tooth. There are two types of the wards incision, which is a wards and the modified ward. So it's always the depth of the impacted tooth will decide the type of the incision, where the incision will get starts from the distal aspect of the second molar teeth, and then from the distal aspect of second molar it should be curving downwards forward to the level of the apex of the distal of the first molar. So this type of an incision is used whenever the linguoverted tooth impaction is present. The posterior part of the incision is same, but the anterior part commences as the junction of the anterior and the middle third of the second molar and runs down to the apex of the distal root of the first molar. So first step is the flap designs and the incision design. To summarize the flap and then incision, the most commonly used incision for the impacted mandibular third molar will be the ward incision, and the modified ward. The incision will always based on the depth of the impacted tooth. Coming into the ward incision, the anterior part of the incision will be starts from the distal aspect of the second molar and it should be curved along the cervical margins of the third molar, and the last part and the posterior part of the incision should be placed towards the cheek region, not along the ramus of the mandible or not along the retromolar region. The most important structure is that the retromolar arteries and the veins will pass through these structures. So whenever the incision is passed along the retromolar region, the patient will have a profuse bleeding which will interfere with the surgical site. So the second one is that the flap reflection. So the flap should be reflected as much as possible for the tooth to be visualized. The third step will be the bone removal. It can be done either with the help of a burr or either with help of the chisel. Each one will have the certain merits and the demerits. If the burr should be used, the length should be a 7 mm, the diameter should be 1.5 mm, and the commonly used to start with a rose head burr and followed by the 701 or a 702 burr. Chisel technique, the width will be 6.4 mm, the length will be 17.5 mm, angulation of the chisel should be at a 45-degree angulation. And there are several other techniques. Whenever we are using a burr, so there should be a sufficient amount of an irrigation in order to prevent the bone. So heat induced injury to the top of bone. So irrigations will be either with help of the saline or with help of the sterile water or a ring lactate solution or a povidone iodine. So why to do an irrigations? So with help of irrigation, you can able to cool the burr. Another thing, as I told in previously, the bone damaging can be reduced and then efficiency of the burr can be improved. So there are several other techniques for the removal of the impacted teeth. As I told, either you can do with a chisel or you can do with a burr. Each one has a certain merits. So the techniques will be a lingual split or a Kelsey Fry technique, which has been popularized by the T. Ward. So it is called as a Tharas Ward and which is proposed by the Sir William Kelsey Fry, and followed by the most commonly indicated for the tooth which is deeply positioned and it's horizontally or distangularly impacted. So what are the steps which is followed in a lingual split technique? First is that vertical stop cut, horizontal stop cut, remove the buccal plate, fracture the distolingual bone, remove the bony wedge, elevate the tooth, reposition the flap, and then finally the final most procedure is a suturing. Here you can able to see and visualize the steps which is involved in the Kelsey Fry technique. The first one will be the vertical stop cut, as I mentioned previously. The second one will be the horizontal stop cut. Third one is that you have to remove the buccal plate. The fourth one is that you have to fracture the distal lingual bone. And then fifth one was that you have to remove that small bony wedge. And then sixth one, elevate the bone, elevate the tooth. And then again, the final most procedure is that you have to reposition the flap and you have to suture it. Another technique is that lingual trephination technique, which has been given by the Boulder Henry, which is indicated for the patient who present with the age group of 9 to 16 years, and where you will place an S-shaped incision. It's made from the retromolar fossa across the external oblique ridge, followed by the elevate the flap and place a define the buccal cortical plate over the third molar region, and the burr is used to make a vertical cut anteriorly and the posteriorly, and using a chisel and osteotomy is applied to the vertical directions over the burr hole. Then the buccal plate is fractured out, expose the third molar cut completely, and elevator is applied to deliver the tooth out of the crut. Any follicle remnant, if it is present, it should be carefully scooped out and with precaution to avoid the injury to that of an inferior alveolar nerve. This is the pictorial representation of the lingual trephination technique. The first step in this is that modified S-shaped insertion has to be placed, followed by the elevate the flap, and the buccal cortical plate is trephined over the mandibular third molar region, and followed by the removal of that buccal plate, and then elevate the tooth, remove the tooth. And the final step, after the removal of the impacted third molar, what are the possible complications we can expect? The complication might occur intraoperatively and as well as post-operatively. Intraoperatively, during the placement of incision, there are chances for the injury to the vessels. As I told that in case of a ward incision, the posterior limb should always placed along the cheek region, not along the retromolar region. If you place along the retromolar region, there are chances for damaging the retromolar vessels. I'm mentioning it again and again, and then there is a chances of profuse bleeding can occur. And during the bone removal, sometimes there is a chances of the slipping of the burr. So sometimes the burr will get split off and it get damaged the adjacent soft tissues, and then it causes a damage to that of the soft tissues as well as to that of the second molar. During an elevation, whenever we give an excess of force for the removal of the third molar without supporting the mandible, there are chances for the bone to get fractured. So fracture of the mandible can occur. Sometimes there are chances for the tooth to get forced into the spaces which is present below the mandible. So which is called submandibular spaces, or the damage occurs to the inferior alveolar canal. During a debridement, the forceful debridement will cause the injury to the inferior alveolar bundle. These are all the possible complications that might occur intraoperatively, and then a post-operative complication which follows. Everyone knows that whenever we are doing any procedure intraorally, the first and the foremost complication will be the pain, followed by swelling and hematoma, bleeding, trismus, infection. The most common is the dry socket, and followed by the TMJ pain, as the patient has to open his mouth for the longer period of the time, paresthesia if the inferior alveolar nerve bundle is get damaged, and then sensitivity. So how to prevent this or how to reduce this? The first and foremost step is that immediately following a removal or surgically removal of impacted teeth, we have to advise a patient to reduce the swelling. So in order to reduce the swelling, we have to advise the patient to take up the medications as well as the applications of the cold over that swelling, and followed by the applications of the heat. So the compressions with the cold will reduces the vascularity over that region, and it will reduce the swelling. So after the 2 days, after the 24 hours, we have to advise the patient to keep the warm water irrigations. So the warm water saline irrigations will cause vasodilatations and increases the vascularity in the regions, and it helps us to remove the debris in that region. Followed by the bleeding. So always pre-operate, intraoperatively, we have to try to reduce the bleeding, and post-operatively, we have to advise the patient not to spit immediately. And then a trismus, it is always better to make sure that you know the anatomical landmarks before inserting the needle inside the mouth. If not, there are chances for damaging to the tough fibers and the trismus will occur. Infections, always do the procedures under the operative. Pre-operatively, you have to do an autoclave all the instruments. You have to do the procedure in a clean manner. Dry socket, as I told you. So advise a patient not to spit, not to smoke for the next 3 days. So that will prevent the dry socket in development. And the paresthesia, and try to avoid the damage to the inferior nerve. So make sure that preoperatively you have done all the investigations related to the of the inferior nerve. CBCT has to be done, or an IANB, and all the assessment has to be done to find out the relationship of the third molar to the nerve to avoid that complications. And then sensitivity will be the last complications which might occur whenever we damage the second molar teeth. So try to avoid the damage to the second molar teeth and try to do an impaction with a pain-free and with a reduced complication for the patient. Thank you. Good morning. We will discuss a little bit about an ameloblastoma. So whenever the term which ends with oma, it indicates that it's a benign type of a tumor. So amelo, so it indicates that the tumor which is developed in relation to the, or the tumor which develops from the tooth forming organ. So amel, as I told you, amel is an enamel forming cells. Blastoma, it's in a tooth. Blasto, it's a tooth germ. So it has been first described in 1827 by Cusack. In 1885, Malus introduced the term name adamantinoma. It may be a unicystic or a multicystic aminoblastoma. So that the most common among them are the multicystic, which follows the 86%, whereas the unicystic, which follows as the 13%. Ivy and Churchill in 1930 gave the term as an ameloblastoma. And there is a certain definitions for the aminoblastoma. The most commonly accepted and used one is the definition which is given by the Robinson in the year of 1937, where he defined the ameloblastoma as an unicentric, non-functional, intermittent in growth, anatomically benign, and a clinically persistent one. WHO in 1991 gave the definition as a benign but locally aggressive tumor with a higher tendency to recur, consists of proliferating odontogenic epithelium lying in a fibrous stroma. What is the pathogenesis which is present behind the development of the ameloblastoma? First is that it can either arises from that of the cell rest of enamel organ, which includes remnants of dental lamina or remnants of Herdwick epithelial root sheath or remnants of the malus. Second one, it can either develop from the epithelium of the odontogenic cyst, which includes the dentigerous or maybe odontomes. The third, there is any disturbances is there during the developing enamel organ, it can give rise to aminoblastoma. The another thing, the basal cells of the normal epitheliums of the jaw can also give rise to aminoblastoma. Or sometimes there is an ectropic epithelium in other parts of the body, especially the pituitary gland, can also give rise to the aminoblastoma. So how the patient will present to us if the patient is having an aminoblastoma? So incidence of aminoblastoma in compared to the other type of oral tumor, it's only 1%. And it's the second most common odontogenic tumor among all other. So the age group of the patient is mostly 30 to 40 years of an age. According to the Richard et al., the male and the female will be then equal predicants. The site, the most common site for the development of the aminoblastoma is the mandible. So the 80% will be the mandible and the 20% will be the maxilla. Among the mandible, the commonest site will be the ramus area, which follows the 70%, premolar is 20, and the symphysis is a 10%. Followed by the maxilla, it's a 20%. Among the 20, the molar will have a 47%, antrum and the nasal floor will have 30%, 33%, premolar and the canine will have 9%, and the palate will have a 2% of chances for the develop site where the aminoblastoma can develop. Always the patient will present to us as an asymptomatic patient. Mostly the aminoblastoma will be the accidental findings. So sometimes the patient will come to us when due to the other complaints. So if we take oral OPG for that patient, we can accidentally find out that aminoblastoma, because it's a very slow growing tumor and it's a locally invasive tumor. Locally invasive indicates that the tumor does not have any capacity to invade the surrounding structures, which means that involving the surrounding structures. Sometimes there is a chances for the tumor to grow in an aggressive manner where it can causes the mobility and the resorptions of the root which is present adjacent to that of the tumor, which result in the mobility of that tooth. As a result of the mobility of that tooth, the tooth gets supra-erupted, the patient will have a malocclusion. Sometimes the patient can present to us with the extraoral or maybe intraoral swellings. And if, as a result of the swelling, everyone knows that swelling will always cause a facial asymmetry. So that a facial asymmetry will be there. Paresthesia. So since the most commonest site, as I told you in the previous slide, is the mandible, and among the mandible, the commonest site will be the ramus region, where the inferior alveolar runs. So this aminoblastoma can develop in aggressive manner, can compress the nerve which is present in that region, and can produce a paresthesia. What is this eggshell crackling? Whenever the aminoblastoma grows in aggressive manner, the bone, so that the mandible is consists of an outer cortical bones and inner cancellous bones. So it involves the bones and it causes the thinning out of the bone. So whenever we palpate that bone, we can able to feel that the crackling of the bone will be similar to that of an eggshell crackling. The final is that sometimes the pathological fracture can occur. Since the aminoblastomas resorbs all the bone surrounding structures, the bone which is present in that region will become very thin. So as a result, the fracture can occur in that region. So mostly the size of that tumor in that region or in any other regions will be in a 1 to 6 centimeter. Occasionally, the patient will also present with that of the pain. So when the pain can occur, there is only one reason the pain will develop: whenever the tumor which has been secondarily infected. So infection will causes the release of the mediators and then produce the pain. So how it has been classified? Aminoblastoma, it has been classified according to the WHO. It's into clinically a solid or multicystic aminoblastoma, as I told, which is a commonest type. Extraosseous or peripheral aminoblastoma, desmoplastic aminoblastoma, or a unicystic aminoblastoma. Histologically, the multicystic aminoblastoma has been classified into follicular, plexiform, acanthomatous, granular, basal cell type, and the desmoplastic one. Whereas unicystic aminoblastoma, histologically, it has been classified into 3 types, which has been given by the Ackerman et al. Into the luminal, intramural, and the mural type, which is the histological classification for the unicystic. As I told, the histological presentation of unicystic aminoblastoma will be a simple luminal, intraluminal, which will be present inside the lumen, or maybe a luminal, or maybe a mural type of the aminoblastoma. And how to diagnose the aminoblastoma? The diagnosis will start from the how the patient present to us. So it's a clinical presentation of that patient, as I told you previously, and then the radiological features of the patient, and the final, and then ultimately the diagnosis will be based on the histopathological features. As I told you, as I mentioned in the previous slide, the clinically, usually the most of the patient will present to us in an asymptomatic patient. Occasionally, accidentally, we can able to find out the aminoblastoma radiographically, or in some cases, the patient will present with a mobility of the adjacent tooth as a result of resorption of the root of the teeth, or else the malocclusion. The patient will be present with an extraoral and intraoral swellings. If it is secondarily infected, the patient will present with a pain. If it is an aggressive nature, it will cause a compression of the nerve, and the patient will present with us the paresthesia. So radiographic features. What is the radiographic features of the aminoblastoma? The classical radiographic feature of the aminoblastoma will be the 2 types. So it will be a multilocular, it will have a multilocular radiolucency. Either it can present as a single small radiolucency as a soap bubble appearances, or it can be a honeycomb appearance. So you can able to appreciate the aminoblastoma which is present in the ramus of the mandible, where the tumor which compresses the inferior alveolar nerve and it causes it. Here you can able to see that multiple honeycomb or so bubble appearances in few areas as an honeycomb, and it causing the resorption of the adjacent teeth, and it is nearing to the of the border of the mandible, which is nothing but thinning of the border of the mandible, where there is a chances for the fracture to occur. As I told, ultimately the final diagnosis, whatever the diagnosis may be in a clinically or in a radiographically, there are certain other differential diagnoses will also be present. Whereas the treatment will always depends upon the histopathological diagnosis. So histopathologically, previous to that of histopathologically, we can do an aspiration. Since it is a tumor, the solid tumor will produce an empty on aspiration, which means that it doesn't have any of the liquid secretion inside it, so that on aspiration we will not find out any of that discolorations or any of the solution. So the final diagnosis histopathologically, it has been based on it. So which is proposed by Wicker and Garland, who has been mentioned that histopathologically the tumor will represent the hyperchromatisms of basal nuclei, palisading of the basal cell, which is nothing but reversal polarity of the nuclei, and cytoplasmic vacuolation of the basal cells. Once we have diagnosed the patient to have an aminoblastoma, what is the management? Management will always follow the type of the aminoblastoma. As I told, the most common is multicystic aminoblastoma, the least common is unicystic. Multicystic aminoblastoma is the one which is an aggressive in nature. So whenever the tumor which has an aggressive type, it is always better to do a radical resection rather than going for the conservative management. Conservative, which is nothing but we are not going to remove the entire jaw. It is nothing. We will remove the tumor and we will conserve the structure which is present in surrounding to that of a tumor. Either we can enucleate the tumor and we can do a chemical adjuvant therapy will be a cauterization we can do in order to prevent the recurrence of the tumor. Whereas radical is the one where we have to prevent the recurrence of the tumor. In such a cases, it is always we will do a removal of the jaw, either an entire jaw or either a part of the jaw or either a small part of the jaw. It always depends upon the size and the site and the position of the tumor. So as I told, enucleation and curettage can also be done. Adjuvant therapy can be a cauterization, either a chemical cauterization using a cornized solution or maybe a cryotherapy. Chemical cauterization, it's most commonly used solution, and the solution has to be freshly prepared on the day of the surgery. So this solution, it can penetrate the cancellous bone up to the 1.5 mm. So where we should use this solution after the removal of the tumor in order to prevent any of the residual part to be left over. So after the removal of the tumor, use this cornized solution, and this cornized solution has a capacity to penetrate the cancellous bone to 1.5 mm to the depth after the 5 minutes of the applications of the cornized solution. Once a cornized solution has applied, it is always better to prevent the damage to the adjacent structures. Always keep a gauze or maybe a Vaseline applied over the adjacent area to prevent the damage to it. What is this cornized solution and what does it contains? The cornized solution consists of the ferric chloride 1 gram, chloroform, glacial acetic acid, and absolute alcohol. So chloroform will be 3 ml, glacial acetic acid will be in 1 ml, absolute alcohol will be in a 6 ml. So since chloroform, it's a carcinogenic, nowadays it has been removed from that of a cornized solution. So the recently introduced using cornized solution will consist of ferric chloride 1 gram, glacial acetic acid 1 ml, and absolute alcohol 6 ml. It has been first used by the Stolinga, where he used a cornized solution and in the patients, in a 5 patients, and found out that there was no recurrence for that patient. From that day, the cornized solution has been started to be used as an adjuvant therapy for these type of aggressive tumor. Followed by the cryosurgeries. Cryosurgery can be done, it is nothing but application of an ice over that region. Application of an ice will kill the tumor cells in that region. Either we can use a liquid nitrogen or a carbon dioxide, and where it will freeze the tissue at approximately of minus 2.2 degrees Celsius and the temperature of below 20 degrees Celsius. So application of this will provide a cellular devitalization. It means that the vitality of the cells will not be there within the bone up to 1.5 centimeter, followed by the resection of the margin has to be done. So to summarize the aminoblastoma, as I told, it's a second most common odontogenic tumor. It can be a unicystic or multicystic. It is the most common site will be the posterior mandible, which is 80% of the site will be the mandible. Among the mandible, 70% will develop from the ramus of the mandible. Size will be either from 1 centimeter to the 6 centimeters. So symptoms usually asymptomatic. Sometimes the patient present to us with a paresthesia or with a swelling. On palpation, so classically, every aggressive tumor on palpation will show a eggshell crackling. Radiographically, we can able to find out the honeycomb or a soap bubble appearance. So treatment, always the treatment will depends upon the aggressiveness and histologically the type of the tumor. If it is multicystic, we have to do a radical resection with continuity or without continuity defect, which is nothing but either we have to prevent the border of the mandible or we have to remove the entire mandible. Entire mandible, it means that along with that of a border, the tumor present at site. Or we can do if it is like unicystic aminoblastoma, if it is a luminal type or intraluminal type of aminoblastoma, we can always do a conservative type of a treatment. As I told, enucleation, which is nothing but the tumor should be removed, followed by the curettage of that area or followed by the cauterization of that region. So as I told, surgical, if we are going for an adjuvant treatment, we have to do a cornea solution or a cryotherapy. And still few authors says that we can either use a chemotherapy using of certain chemotherapeutic drugs can also be used, or we can either use a radiotherapy for the treatment of aminoblastoma. But still it is in a controversy whether we can use a radiotherapy or not for the aminoblastoma. Thank you. Leaf-foot fracture discussion. So leaf-foot fracture, which is nothing but the fracture which is present in the middle third of the face. So the topmost, the structures which will be involved in the leaf-foot will be the most importantly the maxilla. So as I told, it's in a middle third fracture. So the fracture will be in between from the glabella region till the maxillary line regions. So it's a maxilla. Everyone knows that maxilla will have a body and it will have a flow process. The process will be a frontal, zygomatic, alveolar, and the palatine process. So start with the leaf-foot fracture. One should know that classifications of the leaf-foot fractures. There are several classifications are there, which is given by the Gurian, which is in 1886, Rennie Leafoot in 1901, Rowan William in 1985. There are certain modifications for the Leafoot, which is given by the Marciani in 1993, and Donak method classification in 1998. Coming the most commonly used classifications for the mid-face fractures or called as Leafoot fractures will be given by which has been given by the Leafoot, Rennie Leafoot in the year of 1901, where he classified the fracture into Leafoot 1, Leafoot 2, and the Leafoot 3. And it has been again modified by the Marciani in the year of 1993, where he classified into 1, 2, in 2, it has been classified into 2A and the 2B. In a 3, it has been classified in 3A, 3B. In a 4, it has been classified into 4A, 4B, and the 4A and B. Rowe and William classification in the year of 1985, where it has been classified depending upon whether the occlusion has been involved or not. Fracture not involving the occlusion, but further divided into central and the lateral, and fracture involving the occlusion. And first step is that we have to classify the fracture, and once the fracture has been classified, which can be able to which will be help us to diagnose the fracture. So this classifications can be done with help of the radiograph. So the most commonly used and the standardized radiograph to classify the leaf-foot will be the CT. So it's called as computed tomograph. With the help of that, we can able to classify and we can able to identify the level of the leaf-foot fractures, whether it is in level 1 or whether it's in level 2 or whether it's in level 3. So first step is a diagnosis, first step is the classifications, and the second step will be the symptoms and the signs. Signs is one what we identify, and symptoms is the one how the patients present to us. So with the help of that, we can able to differentiate whether it's a leaflet 1 or it's a leaflet 2 and 3. The leaflet 1, the signs and symptoms will always depends upon the site where the fracture have been occurred. For example, if it is occurred at the level of leaflet 1, where it doesn't involve the glabellar region, or it doesn't involve the infraorbital region, doesn't involve the FZ region, or it does not involve the nasal region. So the patient will have swelling of the lip, ecchymosis, and ecchymosis, which will be present in the vestibular region of the maxilla. And sometimes the patient will have nasal block, and then eye and the ocular signs will not be present. As I told, the leaflet 1 level will not involve the maxillary sinus region or floor of the orbital region, glabellar region, or FZ region. So bilaterally, the patient will have epistaxis, which is nothing but the bleeding which fronts the nose. So the Gurian signs. Here it's a picture of the Gurian signs where you can able to see the ecchymosis which is present in the palatal region. Why it occurs? It always occurs due to the damage to that of a greater palatine foramen, where it is present distal to that of the second molar region. Damage to that region, since greater palatine nerves and vessels coming out through that foramen, so damage to that foramen will cause ecchymosis in the palatal region. And what about the occlusion? So sometimes the patients will have an undisplaced incomplete fractures. In such a cases, occlusion will not be disturbed. Whereas if it is completely for one fracture, the patient will have a floating maxilla, which means that the entire maxilla which has been discontinued. So that entire maxilla is not attached to that of other part of the bone, so that the maxilla will be in a floating state. So on palpation, on palpation of the teeth, you can able to hear that cracked pot sound, and the occlusion will get displaced, and then the maxilla, because of the pull of the muscles, the tractions of the pterygoid muscles, which is attached to the tuberosity region, will pull that fracture segment backward and downward. As a result of that, the patient will have the anterior open bite, and since the maxilla has been pushed backward, so the backward pulling of the maxilla will always causes the threat to the airway. And what about the teeth? The teeth, sometimes the teeth will get fractured, and then in case of a leaflet palatal region, so leaflet fractures, so 8 to 15% of all the leaflet fractures will occur along with that of a palatal fractures. It can either a sagittal region, it's exactly in the middle the fracture can occur, or in a parasagittal directions adjacent to that of the midline, or maybe in a multiple comminutor fractures can occur. So in such palatal fractures can occur either in a leaflet 1 along with that leaflet 2 or along with the leaflet 3. So these are the signs and symptoms of the leaflet 1 fracture. First, the soft tissue symptoms. Second will be the occlusion. Third will be the tooth hard tissue which is present in that region. Leaflet 2. As I told that, leaflet 2 is a fractured segment which involve this is a leaflet 2 level, which will involve the nasal bone region, floor of the orbital region, maxillary sinus region. Leaflet 2, it is also called as a pyramidal fracture. Because of the shape of the fracture, it resembles the pyramid. So it's called as a pyramidal fracture, mid-level fracture. So the fracture which occurs below the zygoma, so it's called as a subzygomatic fracture. What are the symptoms? Symptoms will be soft tissue. The patient will have edema of the middle third of the face. As I told, it will always involve the floor. Sometimes it will involve the floor of the orbit. If the floor of the orbit is involved, the important structure which is present in that region will be the infraorbital nerve. Damage to that nerve will produce a paresthesia of the cheek. And the bilaterally, circumorbital ecchymosis will be there, subconjunctival. So below the conjunctiva, the space between the sclera and the conjunctiva, there will be a collections of the blood, so which will be seems to be in a bilaterally subconjunctival hemorrhage. So the patient will have a dish face deformity, and the nose will get depressed since it involves the glabella and the nasal region. And epistaxis, the bleeding obviously will be there since it involves a nasal bone. CSF rhinorrhea. So it starts from the glabellar region, where the most important structures will be the cribriform plate of the ethmoid bone. So in that region, the durameter of that coverage of the brain will get attached. So whenever there is a detachment of the durameter occurs in that cribriform plate region, So there will be the, along with that fracture, there will be the leakage of CSF fluid through the nose. So whenever the leakage of fluid through the nose, it's called as a CSF rhinorrhea. So patients will have a limited ocular movement, which is called as, sometimes it's called as a diplopia, which is nothing but double vision due to that limited movement. Malocclusion will be there. The patient will not be able to open up the mouth in an adequate manner. So it's called as trismus will be there. Step deformity, since it involves a floor, there will be a step deformity. The fracture segment will be mobilized or will be in the mobile state. And as I told, on percussion, you can able to hear the crackpot sound, and then patient will have bilaterally the edema and ecchymosis will be present surrounding the orbit, which will resemble the patient is having a raccoon's eyes. So coming to the Li4-3. So what is that Li4-3? So as I showed you in the previous pictures, Li4-3 is the one where the fracture which occurs at the higher level among the all the two one. So it will cross the orbit and it will involve the FZ region. FZ, which is nothing but frontal zygomatic suture region. So which is similar to that of the entire the half of the face which get separated from the skull base. Then what will be the signs for that patient? Obviously, the patient will have an edema and the patient will have bilaterally periorbital edema, circumorbital ecchymosis, conjunctival hemorrhage will be there, dish face deformity. Similar to that of the Li4-2 fractures, the symptoms will follow depressed nose, flattening of the nose, and epistaxis, rhinorrhea, diplopia, dystopia, hooding of the eyes, anti-Mongolian slant. What is this anti-Mongolian slant? As I told, Li4-3 fracture will involve the FZ suture. So the lateral ligament of the eyes, which is called the lateral rectus muscles, and the lateral ligament will get attached to that FZ suture region. So whenever the fracture which occurs, so you people know that there is called as a white-eyed fractures in case of an pediatric patient. Pediatric patients, the white-eyed fractures can develop. So it is anti-Mongolian slant. So there is a structure which is called as a witness tubercle, which will be present in that the lateral part of the orbit. So in that regions, there is a Lockwood ligament will get attached. So fracture of that FZ region will causes the detachment of the Lockwood ligament, and then the patient will have the slanting of the eyes, which is called as an anti-Mongolian slant. So the patient will have hemotympanum. So tympanum is a structure which is present in the ear. Hemo is nothing but there is a bleeding which is present in that hemotympanum region. CSF otorrhea. So there are chances for that the fluid to get collected in the ear and the fluid to get coming out. There will be a leakage of that fluid through the ear, which is called as a CSF otorrhea. If it is from the nose, it's called as a rhinorrhea. If it is from the ear, it is called as a otorrhea. So the malocclusion, inability to open the mouth, the fracture will be mobilized in the region of nasofrontal suture and the frontal zygomatic suture region. Obviously, the patient will have on palpation the tenderness, which is nothing but the pain will be present all over the region where the fracture is present. And then ecchymosis or the mastoid process will be present, which resembles the battle sign. So how to examine the patients? Always the examinations will start from the eye, ear, and then intraoral. Eye will indicate whether the patient is having a Li4-2 and the Li4-3. As I told you, Li4-2 and the Li4-3, the patient will have the subconjunctival hemorrhage, periorbital edema, circumorbital ecchymosis. Along with that, if it involves a floor, the patient will have a paresthesia. And if it is FZ suture, the patient will have anti-Mongolian slant, and the patient will have a diplopia, which is nothing but double vision. In the ear, the patient will have hemotympanum, and sometimes, as I told, leakage of the CSF from the ear, so the CSF otorrhea will be there. Intraorally, occlusion will get dearranged, the mouth opening will get restricted, and the anterior open bite will be there. The posteriorly, the maxilla will get pushed off. As a result of it, airway threat will be there. Intraorally, Gurian sign, which is nothing but it's an ecchymosis which presented in the greater palatine foramen region in case of Li4-1 fracture, and intraorally the patient will have a mobile maxilla in case of Li4-1 fracture, and intraorally there will be a split, midline split in the case of a palatal region. So it indicates along with the Leaford fractures, the palate also get fractured. Along with that, in case if it is Leaford 1, there will be ecchymosis in case of a buccal vestibular region or buccal sulcus region. Once examination has been done, we have to investigate the patient. Clinically examine the patient first and go to the investigation next. Investigations. So among the investigations, the radiographical investigations, we can either use a Waters view, Caldwell view, lateral view, or submental vertex view. But among these, the standardized view for the investigation for mid-phase fracture will be the CT scan, as I told in the previous slides. So once we have investigated and once the diagnosis has been done based on the clinical as well as the radiographical examinations, we have to plan the surgeries. First step in the surgical planning is that access. So how to access the surgical site? Either we can go intraorally or we can go extraorally. Intraorally, something we are going to do inside the oral cavity to get access to that of a fracture site. Intraorally, vestibule will be there. We can place the incision on the vestibule region. We can elevate the flap and we can able to visualize if it is in a Leaford 1 level. Extraorally, something we are going to do outside the oral cavity where a lower eyelid can be used, incision can be used to approach the fracture, and or a coronal. Coronal is just nothing but bicoronally, the incision will be placed over the scalp region. Or mid-phase deglobing approach, by the entire mid-phase we can able to visualize. Lower eyelid, which has been further divided into subciliary below the cilia, infraorbital below the orbit, or a transconjunctival, or maybe subtarsal. Another one will be a subtarsal. It always depends upon the distance between the lower eyelid margin. If it is 2 mm, it is called as a subciliary. If it is 5 mm, it is called subtarsal. If it is 10 mm, it is called as infraorbital. Or else if it is along the lower eyelid, if it is along the conjunctiva, it's called as a transconjunctival. There is a pictorial representation of intraoral approaches where you can able to visualize the maxillary vestibular incision. This is the incision line. So we have to place the incision along the vestibular region, elevate the flap, visualize the fracture site. In case if the patient is present with edentulous region, so in such cases, it is always better to place the incision along the crust. So everyone knows that there is an alveolar crust. So the incision should be placed instead of in the maxillary vestibular region along the crustal region. So it's a pictorial representation of a lower eyelid incision, as I told. So subciliary, subtarsal, infraorbital incision. So it's a subciliary, subtarsal, and infraorbital, and this one will be the transconjunctival approach. Either we can also use a lateral bow incision in case of a patient present with the frontozygomatic suture fracture, which is involving a Leaford 3, where there is a discontinuity of FZ region. We can use a lateral eyebrow incision. Once the fracture which has been visualized, the second step is that to reduce the fracture into its anatomical position, either manually we can reduce with help of the fingers or with help of the instruments, which is called as a Rose disimpaction instruments. So with the help of that, in this disimpaction forceps, we have to reduce the fracture. So this is a Rose disimpaction forceps. So where we can reduce the fracture which is present in that Leaford 1 level. So this is a one where which helps to reduce the fracture to its anatomical position. So this is a Ayton-William forceps. As I told that some cases the Leaford fracture can occur in association with that of a palatal fracture. So in such a cases, simultaneously we have to reduce the maxilla as well as in case of palate. So along with that Rose disimpaction, we have to use the Ayton-William forces to reduce the palate. Once the reduction has been achieved, once the palate or once the fractured bone which has been reduced to its anatomical position, third step is that fixation. We have to fix it into that anatomical position. It can be either internally or it can be either externally. Internally, we can able to visualize a fracture fragment and we have to fix it. Externally, it is not possible to visualize a fracture fragment and it's not possible to reduce it anatomically, but we can able to fix the fracture fragment. So internal fixation which follows direct osteosynthesis and using a suspension wires. Direct osteosynthesis, the most commonly used nowadays, which will be a mini plate Or maybe intraosseously, directly inside the bone, we can drill a hole and we can place a wire. Where it depends upon the level of the fracture. In case of the fracture is at the level 3, as I told you, for 3, we have to place a wiring at frontozygomatic region and nasofrontal suture region. If it is at the pyramidal fracture, for 2, we have to place a suture at the buttress and the orbital rim region. If it is level 1, we have to place a wiring at alveolar region and mid-palatal region. Suspension wiring, as I told, suspension. So something that the fractured fragment should be suspended to the a stable bone which is present above the fractured site. So whenever, like for example, if it is like Leaford 1 fracture has been there, so that fracture fragment should be suspended to the anatomically stable bone which is present above that region. For example, it has to be suspended to the infraorbital region, or it has to be suspended to the circumzygomatic region, because the zygoma is the next level bone which is presented in case of a Leaford 1 where it is not fractured and is stable. So we have to suspend that Leaford 1 level to that zygoma. So it can be frontal, circumzygomatic, zygomatic, circumpalatal, infraorbital, pyriform. Externally, a craniomandible or craniomaxillary. Craniomaxillary, which follows supraorbital pin, zygomatic pin. POP, we can use plaster of Paris H frame, hollow frame, leaven frame, and the box frames can be used. Always, each and every fractures, what are the procedures, whatever the procedure may be, each procedures will have a certain complications. So in case of a mid-phase fractures, what are all the complications? So before going into the complications, we will summarize the class so that the mid-phase fracture has been classified into Leaford 1, 2, 3. Most commonly accepted one will be the Rennie-Leaford classification. It's given in the year 1901. So the signs and symptoms always depend upon the level of the fractures. So that Leaford 1, which will never involve the orbit or a nasal or FZ region. Whereas a Leaford 2, which will involve the sinus region, orbit and the glabular region. Leaford 3, which involve the glabular region, nasal region, FZ region. So signs and symptoms will always depend upon the structures which involve. Followed by the signs and symptoms, we have seen the investigations. Investigations, first clinically, we have to examine the eye, ear, and the intraoral. Followed by the radiographically, the most commonly used radiographic picture is the CT. Once we have diagnosed the fracture, third step will be the management. The management will always depends upon the level. So in such a cases, first step in the management will be accessibility. Either we are going to access the fracture through intraorally or extraorally. Once a fracture is accessed, once you have reached the fracture site, so first step is that reduce it to the anatomic position and fix it. Followed by the complications. Complications can be an extensive hemorrhage can occur, or airway obstructions can occur, or infections can occur, CSF leak, blindness, plate exposure, lacrimal system obstructions, devitalized teeth, and extraocular muscles damages or imbalance, so diplopia, enophthalmos, orbital dystropia, the changes in facial appearance, nasal obstructions, and the malocclusions can occur. Thank you. Cyst of the oral cavity. So what is the cyst? Cyst is nothing but an epithelial lined pathologic cavity. The definition for the cyst is being given by the Killian K and the Kremer. Killian K gave the definition in 1966, whereas Kremer gave the definition in 1974. So how to classify the cyst? So there are various classification, but among those, I'm going to explain only the classification, which is most commonly accepted one, is the Shear's classification, and the most commonly used one also. So where the Shear classified the cyst into the cyst of jaw, cyst which is associated with maxillary antrum of the sinus, and the cyst of the soft tissue. In case of a cyst of jaw, it has been further divided into epithelial or non-epithelial cyst. Epithelial, it has been divided into odontogenic or a non-odontogenic. And odontogenic, it has been divided into developmental and the inflammatory. And non-odontogenic, which follows these cyst. Non-epithelial, which follows the cyst, which includes simple bone cyst, traumatic, solitary, hemorrhagic, and ABC, which is aneurysmal bone cyst. What are the types? As I told, the mostly generally classified into odontogenic and non-odontogenic cyst. Odontogenic, the name itself is indicate that the cyst which is derived from the tooth forming elements. So it's one, if it, since it is formed from that of a tooth forming elements, it will be only found in the jaws, and they are all local aggressive and rarely malignant tumors. Non-odontogenic, which indicate they are not derived from dental tissues and they can be found in any other regions of the body. So this is a pictorial representation of odontogenic cyst, which is found only in the jaw. One can able to see this is the cyst which present in the ramus, which is called as a OKC, odontogenic keratocyst. And the second one, since it is associated with impacted tooth, it's an aminoblastoma. Third one, surrounding the periapical region, and then it's called as a dentigerous cyst. Sorry, it's called as a periapical cyst. So second one, initially it's surrounded with that of impacted tooth. So it begins as a dentigerous cyst and slowly it will develop into aminoblastoma. And the fourth one will be the empty cyst is associated with empty socket. So it's called as residual. So something which is remaining which gives rise to the cyst. And the fifth one, the cyst which is present in between the molars, premolars. So it's called as a lateral periodontal cyst. Sixth one, cyst which is associating with that of erupting tooth, which is called as eruption cyst. The seventh one is that the cyst is not associated with the tooth, but it's present in the soft tissue of that jaw region, which is called as a gingival cyst. So it's a pictorial representation of non-odontogenic cysts where they are not derived from dental tissues and they're found in any other regions of the body. And what is the embryological derivations of the odontogenic cyst? It can be arising from the dental lamina. So if it is from dental lamina and if it is residual of rest of serous, it's called as a OKC. If it is from enamel organ, if it is dentigerous cyst, if it is from the remnants of epithelial root sheath of the Erdwig, it will be a dental cyst, which is called as apical and radioperiodontal cyst. Among those, the common odontogenic will be a radicular, followed by dentigerous, and followed by the OKC. What is a part of the cyst? So cyst will have a three-part, which includes an epithelial lining of the cyst, centrally the cavity of the cyst, and the surrounding the lumen of the cyst. So the cyst will derive its nutrition from the surrounding connective tissue wall. It can be a true cyst or a pseudocyst. If something starts with pseudo, it means a false. So it's a true cyst. It indicates that the cyst is always lined by the epithelium. Whereas a pseudo is the one, it is not lined by the epithelium. These are the few examples for the true cyst and these are the few examples for the pseudocyst. So what is a pathogenesis? How the cyst forms? So for the formation of anything which is different from that of physiology, it should require some amount of initiation, which includes cyst initiation. First, there is some stimulus which initiate the development and slowly the cyst will start to develop and slowly it will get enlarged. So the first thing is that cyst, so this is a pictorial representation where you can able to see that how the steps which is involved in the formations of the cyst. So what is a cyst formation? So that, as I told, there is any irritant which will stimulate the epithelial lining of the cavity. Once it gets stimulated, the epithelial lining will start to proliferate. So as it gets proliferated, so that cyst will slowly get enlarged. So once it has been proliferated, the central cavity, the central portion of the cyst will be devoid of the nutrition because the surrounding portions of that cyst will not have a chances to penetrate the central region to provide a nutrition. So slowly, if it get proliferated, the central area will get devoid of nutrition. As a result of divided nutrition, the cells which present in the center will get necrosed and will get necrosis and forms as a liquefaction, which is called as a liquefative necrosis will be present. So which will be result in the central lumen of the cyst. So there are certain theories which explains the initiation, which includes Gravitz theory, Sigmund Weber theory, and the Euler-Meyer theory, and followed by the enlargement. So theories which shows the enlargement will be the neural growth, or maybe as a result of hydrostatic enlargement, or as a result of bone resorption factors. So slowly as a cyst develops, it requires space to occupy the bone. So the cyst will stimulate the surrounding structure. So since the surrounding structure is the bone, it will stimulate the bone and it stimulates the cells to start to resorb the bone to occupy the space. So it will resorption will occurs and the cyst will growth enlarges and will occupy the space. So the pictorial representation of the mural growth. There's a pictorial representation of hydrostatic, which is nothing but the fluid from the outside will get enter into the cyst. There's a pictorial representations of the bone resorbing around the cyst, and as a result, the enlargement of cyst occurs. Once the cyst is developed, we have to diagnose it to treat the cyst. As I told, clinical examination is topmost for the diagnosis, followed by histopathological and the radiological. How to examine clinically? Clinically, once the presentation of signs and symptoms, along with that, we have to aspirate it. Each and every cyst will have a certain characteristic features on aspiration. For example, if it is dentigerous cyst, it shows extracellular fluid on aspiration. If it is odontogenic, it shows the dream creamy white on aspirations. And periodontal will be a pale yellow, and infected cyst as follows the brownish fluid or a seropurulent. And the mucosal, ranula, solitary, staphnese will always follow the mucus secretions will be there in mucosal. Solitary cyst, bony cyst will be an empty cavity. Staphnese will have an air-filled cavity, and the fissural will have mucoid fluid. The most common, as I told, dentigerous and OKC. So we'll see detailed about that aspiration fluids content. Dentigerous is the characteristic is cholesterol crystal. The total protein content will be 4 gram per 100 ml, whereas odontogenic will be 5 gram per 100 ml. And then radiographic. So we can take either periapical, occlusal, panoramic, cross-sectional, CT, and MRI. MRI if it is involves soft tissue, CT if it is involves a bone, and if it is larger in size. Once it has been diagnosed in histopathologically and radiographically and clinically, the management will follows based on the characteristic, patient, and the operative factors. So these are the choices of treatments based on cyst characteristics. Always depends upon location. If it is anterior or posterior, a small cyst, a large cyst, or maybe if it is a type of a cyst and the grading of a cyst. Age, it's the most important factors affecting the treatment choice. Age of the patient, medical conditions, tolerance, occupations, lifestyles, and economic status. Followed by the operative factors can be a multidisciplinary surgical skills, prosthetic rehabilitations, whether it's required in case of larger cyst, or maybe a psychological support should be required if it is a larger cyst, whether it requires an entire jars to be removed, the patient should be psychologically supported. So if it is smaller cyst or if it is a cyst, the treatment will follow marsupialization, inoculation, or a resection. Marsupialization, whenever the cyst it is present in younger age group, or we are planning to preserve the tooth associated with that of a cyst, we are planning to preserve the damage to that of adjacent structures, it's always better to go for marsupialization. Or if it is larger cyst, it's better to go for a marsupialization. It can be pass 1 or the pass 2. So marsupialization is that will incise the cyst and will make the cystic lining to be sutured to the oral cavity or the mucosa, and will allow the cyst to get decompressed. It means that the fluid inside the cyst will be allowed to be drained, followed by the cyst will get reduced in the sizes as a result of the depositions of the fibrosis, followed by the excision. Whereas enucleation, which is nothing but the entire cyst will be removed along with the lining. Whereas in marsupialization, the lining will be left over in the oral cavity, and it will be sutured with surrounding mucosal structures, and will allow the cyst to be reduced in a size. Enucleation can be a simple enucleation, or we can enucleate and we can pack this cavity, or we can enucleate, we can curettage, or we can enucleate, but we can do a peripheral osteotomy, which is nothing but following the removal of the cyst, we have to remove 2 mm of bone surrounding it. Or we can do an enucleation with grafting or cauterization, either with cornea or a liquid nutrition. Cornea is a chemical solution which is commonly used for the cauterizations, and it has to be freshly prepared, and it consists of glacial acetic acid, ferric chloride, chloroform, and absolute alcohol. Whereas the chloroform is carcinogenic, it is removed nowadays, and nowadays the carnea solution consists of ferric chloride, glacial acetic acid, and then in case of absolute alcohol. If it is a larger aggressive tumor, either we have to resect the entire mandible, or a segment of the or a part of the mandible, or a segment of the mandible. In case if it is a maxilla, the partial maxilla should be removed, or a total maxilla should be removed. So always the treatment will be depends upon the size, what is the age of the patient, and where the site, what is site, which is like where the tumor is present. Young age group, better to go for, and then larger cyst, better to go for marsupialization, and smaller cyst of 2 centimeter in size, and then it is better to go with enucleation. Larger cyst, aggressive in nature, it has tendency to convert into aminoblastoma. For example, in the case of dentigerous cyst, chances of converting aminoblastoma, better to go with a resection to prevent the recurrence of the tumor. Whereas OKC, since OKC is a highly recurrent tumor, in such a condition, removal of the tumor, enucleate the tumor, or enucleate the cyst, along with that, cauterize that region to prevent the recurrence. Thank you. We will have a small discussion about a periapical cyst. Since it's the most common inflammatory cyst in the jaw, and it is of the odontogenic origin. So it always arises from the cell rest of Herdwick epithelial root sheath, which is the most important cells which is involved in the formation of the root. So the remnants of the Herdwick epithelial root sheath, it's called as a malus. So the cyst which arises from the remnants is called as a radicular cyst. As a result of the periapical periodontitis, so the following any death and necrosis of the pulp will give rise to this type of a cyst. There are various names for these cysts, which includes an apical periodontal cyst, periapical cyst, root-end cyst, radicular cyst. There are 3 types of these cysts, which includes apical, which constitute to 70%, lateral, which constitute to 20%, residual, which constitute to 10%. Lateral, it's one which arises from the any of the lateral canals, and then periapical, which arises from that of the central canal, and it's associated with apex of the root. And the residual, which arises in the region where there is any extracted socket has been there. So as a result of that extractions, if there is any of an irritant which has been left remained in that region, it will give rise to the residual cyst. Periapical cyst, it can be structurally divided into 2 classes, either a periapical true cyst or a periapical pocket cyst. Periapical true cyst, which is nothing but the cyst which contains the cavities, which is like entirely surrounded by the epithelial lining. So whenever there is a true, or indicates that in case of a cyst, it has an epithelial lining, whereas a pseudo, it indicates that the lining will not be there. So resolution of this type of cyst, which requires treatment surgically, such as a cystectomy, which is nothing but the entire cyst has to be removed in order to prevent the recurrence, since the cyst consists of the epithelial lining. Whereas periapical pocket cyst, which is nothing but epithelial lined cavity that have an opening, that opening will be present to that of a root canal of that affected teeth. So which can be easily treated compared to that of a periapical true cyst, where only the RCT, the root canal therapy, will help the cyst to get resolved. What is the pathogenesis? For everything, it requires a pathogenesis to get developed. So pathogenesis for this type of a periapical cyst can be either a caries, or any trauma to that tooth, or any of the periodontal disease, pulpal necrosis, or any necrotic debris, which will be the stimulatory factors for that tooth. So in this picture, you can able to visualize, and you can able to identify, or we can able to rule out the presence of the caries. So these caries will in turn causes a periapical inflammation. So this caries an infectious teeth which will get traveled over the root canal and enter into the periapical region. Periapically, initially, it will not start the forming, it will not present as a cyst. Initially, it will present as a periapical granuloma, which will become composed of granulation tissues, scar, and the inflammatory cells, which provided the rich vascular area to that of the rest of the malus. So this rest of the malus, since it has a rich vascular area, it will start to proliferate in the periapical region, and it forms the larger masses of these cells. As a result of proliferation, the cells will grow, multiply, and forms a mass of these cells. The inner cell of mass will get deprived of the nourishment. So that for the cell to survive or for the cell to develop, it requires adequate amount of the nourishment. Whereas following the proliferation, the cell which present at the inner, not the cell at the outermost, the cell which present at the innermost will deprived of the nourishment. So as a result of it, it will undergo the process called as liquefaction necrosis. So necrosis, which is nothing but the dead bone. So the liquefaction necrosis, which resembles the fluid-filled cavity. So as a result, the cavity will get formed in the center of that granuloma, which results in the cyst, which is called as a radicular cyst or a periapical cyst. So this is the flow chart for the pathogenesis of the periapical cyst. So what are the clinical features for the periapical cyst? As I told, etiology may be a caries or any trauma or any of a periodontal infections. Site, the most common site for the development of the periapical cyst is that maxillary anterior region. Age is at 20 to 60 years of age. So the male to female ratio will be 3:2, usually asymptomatic, and incidentally it's found with the radiograph. So possibly the swelling can occur, but since it's a very slow growing tumor, the obvious swelling will not appear at the initial stage of the tumor. Sometimes it will be painful if it is get infected. So how to diagnose the tumor? How to diagnose a cyst? So always the diagnosis starts with a clinically examination of the patient, either with intraoral, extraoral examination, followed by the radiographic appearance of that cyst in the radiograph, followed by whether the tooth is vital or whether the tooth is not vital, which can be done with help of vitality test, and followed by the confirmatory diagnosis is based on the histopathological appearance. Clinically, as I told that maxillary anterior region, asymptomatic, 20 to 60 years of any age, and sometimes produce a pain. Radiographically, since it's a periapical, so peri, which is surrounding, and apex is the apex of the tooth. So whenever any cyst which is associated with the periapical region, so it indicates that the cyst can be a periapical cyst. So the radiographically, you can able to appreciate that radiographical features. So it's unilocular, a simple oval radiolucency with a well-defined cortical border. And this border can be lost whenever if there is an infection, if it is present. Sometimes it can displace or resorb the root of adjacent teeth if it is get enlarged. So if it is not enlarged, it will be associated with that affected tooth and it will not cause any damage to that of an adjacent tooth. Coming into the histopathology. Histopathologically, it will have usually a brownish breakdown of the plate, straw colored cholesterol crystals will be there, and a cystic fluid on aspiration, you can able to find that viscid yellowish color fluid discoloration. Epithelial lining on examination, one can able to identify or appreciate the non-keratinized stratified squamous epithelium with the rust and bodies will be found. So there are certain differential diagnoses for this cyst. So since the periapical cyst alone will not be present in that region, either it can be initially present as a periapicgranuloma or a periapical scar, sometimes traumatic bone cyst, giant cell tumors can also resemble as same as that of the periapical cyst. So then how to differentiate it? Every cyst will have the same management, but always that the type of a cyst, site of a cyst, age of the cyst, and then the difficulty factors which will indicate the types of the management. Since histopathological features will able to differentiate whether it's in a periapical cyst or a periapical granuloma. Once the confirmatory diagnosis have been arrived, the final step will be the treatment plan. So the choices of treatment may be determined by some factor, as I told, how far the cyst has been extended, whether it's related with other structures, and from where it has been origined, and what is the clinical characteristics of the lesions, and how far the patient will cooperate with the treatment, and what will be the age of the patient. Treatment in case of a radicular cyst will be conventional. So conventional in the sense, it's non-surgical, where a root canal therapy is this enough for the cyst. As I told, the pocket cyst will be still attached with that of a root canal, so that on doing a root canal therapy, the fluid, the cystic fluid will find a path to drain, and then as a result, it gets resolved. Root canal instruments, we have to penetrate that instruments to the center of the radiolucency and establish the drainage and relieve the pressure of that region. Once the pressure has been relieved, the cyst will shrink and then reduced in the size. Subsequently, as the drainage stops, the fibroblast will get proliferate and deposits a few collagen over the region, which causes a compressions of the capillary network. Once the capillary network is get compressed, so that the cells which is present in the region will get deprived of the nourishment and deprived of the blood supplies. As a result of it, they undergo degenerations. And finally they'll get engulfed by the macrophages, which is one of the defense cells which is present in the circulations. So it's called as a monocytes, which is in circulation. When it arises the site, it will convert as a macrophages, so which help us to remove the dead and the debrid products. Or this is surgical treatment. If it is like a true cyst, the cystectomy has to be done, as I mentioned it. So the previous slide. So the cystectomy, like enucleate the cyst, or a marsupilate the cyst, or decompress the cyst. What is the difference between enucleate, marsupilate, decompression? There is simple and then a small differences are there. Enucleation, where the entire cyst will get removed along with an epithelial lining, so that the recurrence for this type of a treatment will be very less. So, but it is not possible for all the type of the cyst. So that the type of the cyst, size of the cyst, age of the patient, as I told and as I mentioned previously, will determine it. A small cyst, a 2 centimeter size of cyst, that can be enucleated. Whereas if it is a larger cyst, and the cyst, if it occurs in young age group and it is associated with that of a tooth, which has to be preserved, or a surrounding structure has to be preserved, or in order to prevent the fracture of the bone, the cyst is larger in size and it's nearer to the lower border of the mandible to prevent the fracture. In such a cases, marsupilization is the only treatment option. In case of a marsupilization, it is nothing but we'll place an incision over the epithelial lining of the cyst, and this epithelial lining will not be removed completely. So we will turn up this cystic epithelial lining, we will suture it towards the oral mucosa. So you can able to appreciate this. Once it has been sutured, the fluid content will slowly get drained off and followed by the fibroblastic deposition of collagen, and then the epithelial, the cyst will get reduced in size. What is a decompression? So we have to decompress. It means that we have to reduce the pressure in that region. So to do that, we have to place in a small hole a rubber tube inside the regions. As a result of it, the fluid will drain off and the epithelium will shrink. And after that, we can able to remove the epithelial lining. And thank you. So to summarize it, so it's a radicular cyst. It's a most common inflammatory cyst. It's also called as a periapical cyst or apical cyst or a rutin cyst. So there are certain certain thing which stimulate the development of cyst. Might be a pathologically, it can be due to caries or it can be due to trauma, it can be periodontal infection. Can be of 3 types, and then the most common among the type is the apical, and the least common is residual. And as I told, it's a 2 type. It's a true one and a pocket one. And the pathogenesis, as I explained the flow chart, how the cyst has been developed. And there are clinically, the most common site is anterior region of maxilla, ages 20 to 60 years. Male is more commonly affected than that of female. Diagnosis can be made with radiological and histological features. Radiographically, it will be an oval radiolucency around the apex of the teeth. If it is an aggressive, it causes a resorption of adjacent tooth. Histopathologically, it is usually a brownish breakdown of the blood. Stalk color cholesterol crystals will be present and rust and bodies will be there. And the management always depend upon the certain factors as I mentioned it, and then conventional treatment or maybe an enucleation treatment, conservative treatment can be done. Conventionally, non-surgically, root canal therapy, surgically, conservatively, enucleation, marsupilation, decompression can be done. Thank you. Dentigerous cyst, which is the most common, it's a most common type of an odontogenic cyst, and it's always and mostly associated with that of a mandibular thermola. It's not only associated, it's mostly associated with that of it. So let's see let's have a small discussion about it. What is this? Who gave the term of a dentigerous cyst? In 1908, Page gave the definitions, gave the term of a dentigerous cyst. It's also called as a follicular cyst. It's the second most common and type of an odontogenic cyst. 20 to 24% of all the jaw cyst constitute of dentigerous cyst. It is usually encloses the crown of the unerupted or an impacted tooth as a result of expansions of the follicle which is attached to the neck, which is caused by the accumulations of the fluid between the reduced enamel epithelium which is present surrounding the crown of the tooth and then enamel surface resulting into the cyst. So, how to differentiate? Normally, the erupting teeth will be surrounded by the follicle. So, to differentiate whether it's in a cyst or it's in a follicle, whether it's a cyst or it's a normal erupting teeth, the follicular size will determine. So, one of the determining factor, it's not a complete determining factor for to diagnose it as a dentigerous cyst. The normally follicular space is approximately 3 to 4 mm, whereas a dentigerous cyst can be suspected whenever the space is more than a 5 mm. So this is the impacted tooth with surrounded follicle. If the space between the impacted crown or the tooth and between the follicle, if it is more than a 5 mm, it indicates that the dentigerous cyst is slowly developing. And what are the types of the dentigerous cyst? It can be either a developmental, due to the developmental factors that it can develop as a result of the erupting tooth, which will impinges the surrounding follicles. As a result of this, there is an obstruction to the venous outflow and accumulation of the fluid will cause a cyst. Or it can be due to the inflammatory. Inflammatory, either it can arise from that of a pre-existing tooth or a surrounding infections of the tooth will stimulate this epithelial lining and gives rise to the cyst. What will be the clinical features for the patient who is present to us with a dentigerous cyst? First and the foremost is the site. As I told, it's mostly associated with that of mandibular third molar, and the least common is called as a mandibular premolar. Age, age, as I told, it's like since it is associated with that of an impacted tooth. So mostly the tooth will get impacted when the patient is in age group of 20 to 30 decade of the life. It means that second to third decade of the life. It's not 30, it's a second to third decade of the life. It may be a small and asymptomatic one. If it is like asymptomatic, it's very difficult to diagnose it clinically. So its diagnosis only can be done on a routine radiograph, which is taken for some other reasons. So either it has been taken for imaging to investigate the delayed tooth eruptions or to investigate some other reasons. Or it can grow large enough to produce a painless bony expansion, and it can displace the involved tooth and cause a resorption of the adjacent tooth. Pain will be there if the cyst is get secondarily infected, and paresthesia will be there if the cyst compresses surrounding nerve. Displacement of the tooth will be there if the cyst compresses and displaces the tooth. So there are certain syndromes are associated with that of the dentigerous cyst, which includes Martex-Lamy syndrome, cleidocranial dysplasia, basal cell nevus syndrome, Garner's syndrome. So these syndromatic patients will have the dentigerous cyst. So there are chances for the syndrome patients to have the syndromic patients to have the dentigerous cyst. How to diagnose it? All the pathological conditions for that pathological diagnosis will start with clinical, radiographical, and histopathological. Clinical, as I told, mandibular, impacted third molar. Clinically, a larger cyst only will produce symptoms. Smaller cyst will never produce any of the symptoms and the signs. Larger cyst will produce the signs and the symptoms like paresthesia, swelling, malocclusion, displacement of the adjacent tooth, mobility of the adjacent tooth, resorptions of the adjacent root of the tooth. Radiographically, as I told, dentigerous cyst is mostly associated with that of the impacted mandibular third molar. So radiographically, it presents to be an unilocular radiolucency surrounding the crown of the impacted teeth. Radiographical relationships between the tooth and the cyst has been described to be a central variety. You can able to appreciate where the uniocular radiolucency is surrounding the centrally crown of the tooth, laterally around the tooth, laterally crown of the tooth, circumferentially, not only the crown, along with the crown, few part of the root also can engulfed within the radiolucence. So radiographically, it can be either a central coronal or lateral or circumferentially surrounding the crown and the root. The radiolucent structures will get surrounded by the, the crown and the root of the tooth will get surrounded by the radiolucent structure. So it's an orthopantomogram which shows that, so the dentigerous, the lateral type of a dentigerous cyst is associated with that of impacted tooth. So here you can able to appreciate the type of a dentigerous cyst which is associated with that of the impacted tooth. Histopathologically, how to identify it? So the most common is aspirations. On aspirations, one can able to get a straw color, clear straw color fluid will be there on aspiration. And on histopathologically, after that treatment of the cyst, we can able to identify the non-keratinized epithelial lining, inflammatory cells infiltrate if it is due to the inflammation, cholesterol cells and their associated multinucleated giant cells will be present. So it's an aspiration picture, so it shows the straw colored fluid. And what are the differential diagnosis? So either immunoblastoma will also arise from the impacted tooth, or OKC, it can be present in that region, but OKC will not be associated with that of a in the region of mandibular thermolar, always it present in the ramus of the mandible. Odontogenic fibroma, it can be myxoma, but myxoma will have a radiographically tennis rocket appearance. Whereas dentigerous cyst will have unilocular radiolucency appearance, or it can be cementomas. So the one standard method to differentiate all other thing from the particular cyst is that for every other pathological condition, the only gold standard things to identify the particular type of that pathological condition will be the histopathological feature. Coming into the treatment plan for the dentigerous cyst. For all the cysts, the treatment plan will always be based on the size, location of the cyst, and the age of the patient. It can be a total enucleations or the marsupializations. For every cyst, the treatment, the long-term follow-up should be required in order to identify the recurrence. In case of the dentigerous cyst, there are 33% of the cyst as a chances to develop into the benign type of a odontogenic tumor, which is called as ameloblastoma. Rarely, the epithelial lining of that cyst, which can give rise to the mucoepidermoid carcinoma, squamous cell carcinoma, or either the squamous cell carcinoma develops from the epithelial lining. So to summarize it, so the dentigerous cyst, which is the second most common odontogenic cyst, and 20 to 24% of the jaw cyst constitute to be an dentigerous cyst. It's also called as a follicular cyst associated with impacted mandibular third molar, and it's approximately 3 to 4 mm the normal follicular size, whereas in case of a dentigerous cyst, the follicular size will be more than a 5 mm, and type of a dentigerous cyst will be a developmental cyst and an inflammatory cyst. And clinically, the mandibular thermolar is common site. Age is second to third decade of the life, and usually a small cyst will be appears to be asymptomatic. Larger cyst will produce the symptoms like expansions of the bone, resorptions of the root of the adjacent teeth, and then paresthesia if it is compressed surrounding nerve, pain if it is infected. So the syndromes which is associated with that of a dentigerous cyst will be the Mattax-Lamy syndrome, cleidocranial dysplasia, basal cell nevus tremor syndrome, and the Garner syndrome. And the diagnosis is always clinically, radiologically, and then histopathological features. So based on these three types, the diagnosis can be done. Clinically, as I told, and radiographically, it has three types, either a central, lateral, and the circumferential. And then histopathologically, aspirations of the fluid will have these straw-color fluid aspirations, and it has an inflammatory cell infiltrate if it is infected and if it is due to the inflammation, and then the cholesterol crystals, non-keratinized epithelial lining will be there. Management either enucleations or marsupializations, and there are certain, it will sometimes it gives arises to the immunoblastoma, mucoepidermoid carcinoma, squamous cell carcinoma. Most important things to be noted in case of a dentigerous cyst is that the development which has been given by the Mainz theory in 1970, where they have mentioned that, as I told in the case of developmental type of a cyst, where they have mentioned that the pressure of that erupting teeth The pressure of the erupting teeth on the impacted follicle obstruct the venous outflows and the serum transduction across the capillary wall, which in turn increase the hydrostatic pressure of the pooling fluids, separates the follicle from the crown. So it is the most important theory which is proposed by the Mings in the year of 1970 to explain about the how the dentature cyst gets developed if it is not due to any of the inflammatory causes. So there are 33 percentage of the cyst may develop into aminoblastoma, rarely carcinomas, squamous cell, and can develop from the epithelial lining. Thank you. Internal skeletal fixation, which is one of the type of the fixation which is most commonly used in a case of patient is present with a trauma. So it's a type of a non-rigid osteosynthesis. There are a rigid and a non-rigid type of osteosynthesis in case of a fixation of the fractured bone. In that, intraskeletal fixation is a non-rigid type. It can be in a suspension wiring, either a frontal or a circumzygomatic or a zygomatic, infraorbital, pyriform, and the nasal spine. We'll discuss that each one where it is indicated. So suspension wiring, which is nothing but a fractured segment has to be suspended with a stable segment which is present above that. For an example, in case if the patient is present with a Leafoot 1 fracture, so the fracture which is present along the line of the maxilla, it doesn't involve the structure above the maxilla. So that fracture segment has to be suspended to the structure which is present above it. So what are the structures? The stable structures above the level of the maxilla will be a zygoma and then infraorbital region. In that region, the wiring has to be done. Whereas in a case of a patient who's present with that of the Leafoot 2 and the Leafoot 3 fracture, a frontal suspension wiring can be done. Or in else, the patient present with the Leafoot 2, the circumzygomatic can be done. In a case of pyriform picture, Leafoot 1, and in nasal spine, in case of a mandibular fracture. Whereas in case of mandibular fracture, the fracture segment can be reduced and fixed along with the nasal spine. Certain armamentarium, a special armamentarium which is required. The armamentarium will not be as same as that of an armamentarium which is required for semi-rigid type of fixation, which includes mini plate. In case of a non-rigid type of interskeletal fixation, the armamentarium includes bone awl and then a BP blade in order to place an stab incisions and the 26 gauge wire, and in case of a curved artery forceps. So it's a pictorial representation of a frontal suspension wiring, whereas in case of patient present with the Leafoot 2 and the Leafoot 3, since this wiring it is present above the level of Leafoot 3 as well as a Leafoot 2. Even it's also present above the level of Leafoot 1, but for a Leafoot 1, the stable bone are more adjacent to that is zygoma and infraorbital rather than the frontal bone. So in case of Leafoot 3 and the Leafoot 2, the stable bone is above it is the frontal wiring, where a central and the lateral can be done. In case of a central, you have to place a stab incision in the glabellar region and incise this and then elevate the flap, dissect the tissues, elevate the flap, place the screw. The screw should engage the outer cortical plate and then passes the wire intraorally, pass the wire through the arch bar, and then using a bone awl, the wire should be passed to the region where the screw has been placed, and the wire should engage around the screw, and again it should be turned back and fixed to the arch bar. In case of laterally, the lateral brow incision has to be placed, dissect the tissues, place the drill, and insert the screws. The screw should engage in the outer cortical plate, pass the bone awl along with that of 26 gauge wire from the arch bar along the maxillary vestibular region below the zygomatic arch region until it comes out through the hole which has been placed in the FZ region. From that, engage the wire over the screw and turn back the wire along the same maxillary vestibular region, engage the wire to the arch bar to stabilize it. Infraorbital, the suture has to be the incision and the drill has to be placed along the infraorbital rim and pass the wiring and fix the wire. One end should be attached to the arch bar and other end should be passes through the hole which is placed in the infraorbital rim and stabilize it again with the arch bar. And this is a picture representation of circumzygomatic wiring. You can able to visualize it. The bone has been passed through the maxillary vestibule region behind the zygomatic arch. The wire has to be engaged over the tip of the bone, and the wire which has been came out through the same zygomatic arch behind the zygomatic arch region and the place where the incision has been placed, and secure the wire, the same wire, to the arch bar. So it's again a picture representation of circumzygomatic. And it's a pyriform picture where it can be used in patient present with a Leafoot 1 fracture, where the fracture line runs along the maxillary region. Engage the wire to arch bar and place a hole along the pyriform rim. Pass the wire through the pyriform hole and again fix the engage the wire to the arch bar. It's a nasal spine suspension wiring which is used for the mandibular fracture. Pass the wire from the mandible till the nasal spine and secure it back to the mandibular fracture line. Circumpalatal as well as a peralveolar. Circumpalatal. So in case of the patient which has been present with that of the palatal fracture. So the palatal fracture can be reduced with Hayton Williams forceps and then it has to be fixed. So since the plate fixation can also be done, but the vascularity of that region is very less. So in order to prevent the necrosis, palatal wiring can be done with the help of the patient's own denture. Place the own denture and pass the wire through that of the denture to the palate and secure that denture along with secure the denture with the help of the wiring along with the reductions of the palatal fracture. Peralveolar wiring, it's most commonly used in case of patient who is present with the gunning splint where the patient's own denture has been modified to make it as a gunning splint where the gap will be present only in the anterior region for the feeding for the patients. So that gunning splint, so since it has to be secured, it requires some wiring. So in such cases, peralveolar wiring, peralveolar, so that the wiring has to be done along the alveolus, insert the wire, pass the wire through the alveolus, and secure back the patient's gunning splint to that wire and then fix the gunning splint along with that of the fix the gunning splint with help of this wire. So the wire has to be passed from the alveolus and other end of the wire to be passed through the gunning splint and again turn back the wire and pass the wire through the alveolus and secure the wire. One of the disadvantages of using this type of the non-rigid type of fixation is that there are chances of the recurrence. It means that a relapse can occur. It's not a recurrence, a relapse can occur. And another thing, disadvantage is that we cannot able to directly visualize the fracture fragments. Or other than that, indirectly the fracture can be reduced. So one cannot be able to predict whether the fracture has been reduced to its anatomical portion. Whereas other advantage is that the procedure will not be a longer period, it will not take a longer period of the time. And it's a very small procedure. Even the procedure can be done under the local anesthesia, and the procedure can be only a few armamentariums only required for these type of the procedure. So as I told, the advantages, the conservative can be done even in the patient who has been medically compromised and the patient was not fit for the general anesthesia. The disadvantages is that it's not rigid and it exerts a backward pull which might lead to the relapse. Thank you. Neck dissection, which is nothing but it's a part of the treatment of oral cancer, where the lymph nodes that contains the cancer are removed. So coming to the introductions, there are certain cancers which present in oral cavity. They have a capacity to spread to the adjacent structures, either through the blood or through the lymphatics. If it is spread via the lymphatics, it will produce the nodal metastasis and it produces a swelling in the neck regions and which can be determines the spread of the tumor. The nodal metastasis, which is the most important clinical and pathological prognostic factors, especially in patients who is present with the squamous cell carcinoma of head and neck region. So the presence of even a one positive lymphatic node is associated with the 50% of reduction in the survival rate of the patient. So what to do and when to do the neck dissections, what are the types of the neck dissections, and what are the incisions used for the neck dissections, and how to identify it, we'll see in the upcoming slides. So before that, one should know the classifications of the tumor. So which is called as a tumor nodal metastasis classification, which has been given by the ACCN guidelines, which is nothing but associations of the cancer guidelines. In that, they are being revised the classifications and they revised the staging. In the 8th staging, where they have added the depth of invasion in case of tumor, and in case of a node where they have added the extranodal extensions. These two terms will not be present in case of the previous TNM staging. In the T1, they have added the depth of invasions to be less than 5 mm, and in the T2, they added the depth of invasion in between the 5 to 10 mm, and T3, they added the depth of invasion more than 10 mm. Beyond this, there is no differences which is present between the 7th TNM staging and then 8th staging. What is this depth of invasion? So, which is nothing but the, so that the consider that the cancer cells, so it indicate whether it has been invaded into the adjacent structures and how far the invasion has been present. So that which will determines the treatment planning for that patient. Coming to the TNM, and then it's a nodal staging. Nodal staging, so that it can, difference between the 7th and the 8th TNM classification is that they have added extra nodal extensions where it is positive only in case of an N3B and N3 stages. What is extra nodal extension? Which is nothing but the tumor which spreads beyond the nodes and then it enter into the surrounding structures. So which indicate that the tumor nodes which starts to spread to the surrounding structure. So this is the pathological nodal staining and this is a clinical nodal staging. Where in a clinical nodal staging, in N3 stage, the extranodal extensions has been positive. In a pathological nodal staging, N2A, the extranodal extension has become a positive. So what is this various terminologies have been there in case of a neck dissection. So what is this? When to do a neck dissection and in which condition we have to do a neck dissection. Neck dissection, as I told, the removal of the nodes which has a cancer cell. So when to do? Almost in all the stages of the cancer. In case of a current studies, it states that in order to prevent the recurrence of the tumor and in order to prevent the leftover residual tumors, it is always better to do a neck dissections in all the stages of the cancer. It can be either an elective one or it can be either a therapeutic one or it can be either a sentinel lymph node biopsy. After that confirmatory, we have to do that. What is elective one and the therapeutic one? Therapeutic, whenever clinically and then radiographically, it indicates that the tumor has been spreaded to the node. In such a cases, definitely we have to do a neck dissection and we have to remove that neck and then that involved node to prevent the recurrence. So what is this elective? Elective is just nothing but in case there are chances of spread of the tumor. So we suspect that the tumor might have been spreaded to that of nodes. So there are certain micrometastases which cannot be seen through that of a naked eye or it cannot be captured by that of radiographic pictures. Where we, in order to prevent the spread, we can do an elective neck dissections. Invariably, whether the tumor has been present or not, in all the stages, we have to remove the node. So this is the current scenario to do the neck dissection. The terminologies which include the radical neck dissection, modified radical neck dissections, which has been further divided into modified radical neck dissection 1, 2, 3, extended radical neck dissection, and the selective neck dissection. In radical neck dissection, we'll remove all the level 5 of the lymph nodes. The lymph nodes in the neck region has been divided into level 1, 2, 3, 4, 5, 6, and a 7. What is this level 1? 1, which has been again divided into 1A and the 1B, which includes the lymph node which is present in the submental region and the lymph node which is present in the submandibular region. Level 2, it starts from the base of the skull to the hyoid bone, where the 2, which has been again divided into 2A and the 2B by the spinal accessory nerve. Level 3, which starts from the hyoid bone to the cricoid cartilage, whereas level 4, which starts from the cricoid cartilage to the clavicle. Level 5, the lymph node which is present in the posterior triangles of the neck which is bounded on the one side by the posterior borders of the sternocleidomastoid muscle, and another side it's bounded by the anterior border of the trapezius muscle. And the level 6 is one which is bounded on either side by the internal carotid artery, and then above it's bounded by the iliac bone, and the below is bounded by the clavicular notch. So in radical neck dissection, all the 5 lymph nodes has to be removed. Whereas one of the disadvantages of doing a radical neck dissection is that along with that lymph node structure, certain non-lymphatic structures are also removed. So in that, the non-lymphatic structure in that, it includes the sternocleidomastoid muscle, spinal accessory nerve, and internal jugular vein. One of the disadvantages in doing this radical neck dissection is that compromising the spinal accessory nerve, so the patient will have a drooping of the shoulders. So that they started introducing the modified radial neck dissection, where it has been divided into 1, 2, 3. The first type, the spinal accessory nerve has been preserved. The second type, along with the spinal accessory nerve, the internal jugular vein has been preserved. In third type, all the 3 non-lymphatic structures, which includes spinal accessory nerve, internal jugular vein, sternocleidomastoid muscle, has been preserved. So selective neck dissection, which has been divided into supraomoid neck dissection, lateral neck dissection, anterolateral neck dissections, and the posterolateral neck dissections. In supraomoid, 1 to 3 structures, 1 to 3 level of the lymph nodes has been removed, but all the 3 structures has been preserved, which is the non-lymphatic structures. In a lateral neck dissections, 2 to 4 level 2 to level 3, level 4 has been removed, and all the structures has been preserved. In anterolateral, level 1 to 4 lymph nodes have been removed. In posterolateral, 2 to 3 2 to 5 levels of the lymph node has been removed. And then extended neck dissections, where 1, 2, 3, 4, 5 lymph nodes has been removed, and one or more additional lymph nodal groups such as a paratracheal or anterior compartment lymph nodes has been removed. And the structures are removed such as a carotid artery, hypoglossal nerves, and the vagus nerves are removed in the case of extended neck dissection. As I told, when to address the neck. So when to do the neck dissections. Either you can do it as an elective neck treatment. I mentioned it in a previous slide. As an elective neck treatment in order to prevent the micrometastasis, because according to the Weiss et al., you have mentioned that there are chances of 20% of occult metastasis to occur. So to prevent that, elective neck dissection has to be done. So always that nodal metastasis will depend upon the site where the tumor has been present, and how far the size and the grading of the tumor, and how far the depth of the tumor, whether the tumor has been invaded in the peripheral surrounding nerve structure or in the surrounding arteries. If the tumor of very small inside, less than 2 centimeter size, present in the anterior tip of the tongue, and then grading of the tumor is like that grading, which has been divided into moderately, well, and the poorly differentiated histologically. If it is like well differentiated tumor and the depth of invasion is less than 5 mm, there is no invasion into surrounding structure. In such a cases, it's better not to go for a neck dissection. Whereas larger size tumor, poorly differentiated tumor, and more than 5 mm of invasion and invading the surrounding structure, in such cases, it is always better to go a neck dissection to prevent the recurrence of the tumor. And it's always like, in case we are going for an elective neck dissections, up to what level the tumor has to be removed. So up to the level 3, in case of the elective neck dissection involving all the structures other than the tongue. Why not in the tongue? Since in case of a tongue, there are chances for the tumor to get metastasis to the level 4 also, leaving the level 2 and level 3. So that is called as a skip metastasis. Whenever the tumor is present in the tongue region, if the tumors in such tumor, if it is spreads through the lymphatic, if it is involves 1, 2, in case of a tongue, the tumor can skip the 3 level and the tumor can enter into the 4th level. So in case of the tongue cancer developed from the tongue, it is always better to go with level 1 to 4 node as to be removed as a part of the initial therapy to prevent the recurrence. So there are various studies have been still in the process to find out whether the elective as a better treatment or a therapeutic neck dissection has to be done. According to the conclusion, in always, if to prevent the recurrence of the tumor, it's better to go with a elective neck dissection rather than that waiting for the tumor to get spread into the lymph nodes. So to summarize, a neck dissection, which is nothing but it's a part of a surgical procedure in case of a patient present with a cancer in the oral cavity, in order to prevent the recurrence where the lymph node which containing the tumor cells are being removed. There are 7 levels of the lymph nodes which is present in the neck region, starting from level 1, which is present in mental and submandibular region, level 2 upper deep cervical lymph nodes, and level 3 is middle deep, and the level 4 is lower deep, level 5 is posterior triangle, level 6 is anterior compartment lymph nodes. So along with that, so that neck dissections, the various terminologies has been mentioned: radical, selective, extended, and then modified radical. In radical, along with the lymphatic, the certain non-lymphatic structures are also removed, whereas in case of modified, in modified number 1, the spine axillary nerve has been preserved. Number 2, axillary nerve and vein has been preserved. Number 3, all the 3 non-lymphatic structures, which includes accessory nerve, sternocleidomastoid muscle, and then jugular vein has been preserved. As I told, selective, it includes a supraomoid neck dissection, and then a lateral, anterolateral, posterolateral. Extended, it includes 1 to 5, and along with a certain other non-lymphatic structures. And when to address the neck, it's always better to go with a neck dissection in all the stages of tumor. Either it can be stage 1, either it can be stage 2, or it can be stage 3. To prevent the recurrence, to prevent the micrometastasis, better to go with the elective neck dissection. And there are staging which is revised by the ACCN guidelines. According to that, 8th tumor staging, which is revised from the 7th, where they have been included depth of invasion in the tumor staging and in externodal extension in case of a nodal staging, and all other follows the same as that of the 7th ACCN guidance of TNM staging. So to prevent the spread of the cancers and to prevent the recurrence, always better to go with the elective neck dissection rather than that of the therapeutic neck dissection. So thank you. Ludwig's angina. It is one of the space infection which includes bilaterally submandibular, sublingual, and submental spaces. It's a firm, acute, toxic cellulitis of submandibular and sublingual spaces bilaterally and of submental spaces. It's rarely a fluctuant and often a fatal since it involves the lower jaw spaces. There is always chances of the obstructions of an airway. The patient will always have a sensation of choking and then suffocation. It has been described by the Ludwig in the year of 1836. What is the etiology for that to occur? So 90% of it arises from the dental origin, or else it can arise from submandibular sialadenitis or a compound mandibular fracture, which is nothing but the fracture which is exposed to that of an external environment. Oral soft tissue laceration, punctured wound or floor of mouth, secondary infection of the oral malignancy. As a result of it, the infection is spread to the tissue spaces. What are the stages of the infections? To infection to occur, it has to undergo through the various stages. First, initially inoculation. It's a first stage where the microorganism enter into the structure. So second is cellulitis. Slowly they started to develop the inflammation, which will get a result in the reddened heart and painful swelling with the loss of the function. Third is the abscess, where the necrosis can begin to be developed, with the center of softening of cellulitis mass, which in turn gets fluctuant. Final is resolution. This is a final stage where the body, the human body, the immune systems which overplay it, and then therapeutic drainage will occur with the use of either medications and along with that of immunity. So there are certain factors which also affect the spread of infections. It includes microbial factors, whereas the quality and quantity of microorganisms, how far the quality of microorganism and how amount of the microorganism will determine the spread of infection. Host factors, which include the level of the immunity and state of the immunity of the individual, and the combinations of the both along with the local factors that There are certain structures which will resist the spread of infections, which includes the fascia, bone, muscles, that also determines the spread of infections. So what is this fascia? So the fascia, which is nothing but one of the structure which will prevent the spread of the infection, which is nothing but it's a sheet of the dense connective tissue. That structure will separate the certain structures which passes over it during the time of the movement. So coming to the fascia of head and neck, there are several fascias like superficially and the deep cervical fascia. The deep cervical again has been divided into anterior, middle layer, and the posterior layer. So the base, depending upon this layer, the spaces will be there, and then infection spread will also occur. Spaces, it has been divided into direct and indirect spaces. So direct spaces are a primary and the secondary spaces. Direct is a primary space, secondary is the indirect space. Primary space of maxilla includes canine, buccal, infratemporal space, whereas a mandible, it includes buccal space, submental space, submandibular space, and the sublingual space. Indirect secondary spaces, it includes masseteric space, pterygomandibular space, the pterygomandibular space, superficially deep temporal space, parotid space, later pharyngeal space, retropharyngeal space, and the prevertebral space. These facial spaces has been classified depending upon the severity score into the low, moderate, and the high space. So low severity scores have been based on the anatomical space. It includes vestibular, subperiosteal space of body of mandible, infraorbital buccal, and the moderate space includes submandibular, submental, sublingual, pterygomandibular, and etc. High, it includes retropharyngeal, retropharyngeal, and the pretracheal. So coming into the Ludwig angina, as I told, it involves the submental space, which has been bounded on either side by the digastric muscles, hyoid bone, and the chin, where it includes several submental lymph nodes in that region. So where sublingual spaces, it is also the one of the space which is involved in case of a patient who has been presented with that of the Ludwig angina, since the sublingual space which will be present directly over the directly over, above the molar region, it will be mostly engaged in cases of a Ludwig angina. It is bounded superiorly by the mucosa covering the floor of the mouth, inferiorly by the myloid muscle, posteriorly by the body of the hyoid bones, and then anterolaterally by the inner aspect of the body of mandible, and then medially by genioid, genioglossus, and styloglossal muscles. What does it contain? It contains a submandibular gland, part of the gland, which is a deep part of the gland, Wharton's duct, sublingual gland, and the nerve, a lingual hypoglossal nerve, terminal branches of the lingual arteries. And then coming into the most important and then a most part of the space, which is nothing but it's a submandibular space. So this submandibular space is the one which lies between the myloid muscles and it overlying the superficial layer of deep cervical fascia and the platysma. The posterior extent of submandibular space is communicated with the deep facial space of the neck. In such that conditions, whenever the infection involving submandibular spaces, there are chances of spreading that infections to the later pharyngeal, retropharyngeal spaces and causes the obstructions of the airway. So this submandibular space, so that it contains the submandibular lymph nodes and then submandibular Wharton's duct, lingual nerve, hypoglossal nerves, branches of arteries, and submandibular gland. So it's a pictorial representation of how does the infection spreads from one spaces to the another spaces. It crosses the myloid muscles and involves the submandibular spaces, and via the submandibular spaces, it will enter into the other deep facial spaces of the neck. As I told, the communications via the submandibular spaces that enter into the later pharyngeal, retropharyngeal spaces and produces various types of the complications. And how the patient present to us if the patient is having a Ludwig angina. Clinically, the patients will have a bilateral swelling of submandibular, submental, sublingual region. And since it is an infection, the patients will have a severe pain and the patients will look toxic. Since infections involving the lower jaw, the swelling will get difficulty and the patient swallowing will get difficulty and the patients will have difficulty in swallowing. speech will get affected, and increased temperature, which is nothing but marked pyrexia, will be there. And then a swelling will appear to be in a browny swellings, muscle spasms, trismus, obstructions, dilation of alanicia will be there. Intraorally, since it involves sublingual submental spaces, which pushes the tongues superiorly and causes a rising of the tongue, rises the floor of the mouth, which makes the swallowing difficulty and drooling of saliva. Even a death can occur if the patient is not treated within a 24 hours due to the asphyxia. There are cardinal signs for the lubic agena, which includes a bilateral involvement, gangrene with the serous sanguineous, putrid infiltrations, but the frank pus will not be there in case of a lubic angina. And its involvement of the connective tissues, fascia, muscles, but the glands which is present surrounding that structures will not get involved. The spread of the infections always via the facial spaces rather than via the lymphatic tissues. So, certain dangerous signs for lubric angina, which includes dyspnea, difficulty in the breathing, dysphagia, difficulty in swallowing, hoarseness of voice, changes in the voice, strident, and then a swelling below the clavicles. These are the dangerous signs for the patient present with the lubric angina. How will I identify whether the patient is having lubric angina? Obviously, clinically, patient will have a bilateral swelling. Along with that, the conventional radiograph, which includes IUPA, orthopantomogram, lateral view of mandible, anteroposterior view of the neck. Another diagnostic aid is a CT scan, MRI, and the nuclear medicines and the zero radiography is also used in the diagnosis of the lubric angina. What are the steps in the management? There are certain steps which has been there for the management of the lubric angina. First is that we have to identify the severity of infection. Second is that immediate care has to be given to the patient. Third, we have to treat surgically and support the patient medically with help of antibiotic therapy and observe the patient how far the patient is respond to that of the therapeutic treatment. And the patient should be under the regular checkup for the airway management. As I told, there are the principles for the management of space infections. These principles will include an acute and the chronic infections. If there is an acute infections and there is no signs and symptoms other than the pain, it can be treated with a medical therapy using an antibiotic and the drainage and the removal of that offending tooth. Whereas if it is a chronic infections and the airway assessment and management has to be done, starts with that. Initially, it's very difficult to find out the organisms which causes that infection. So that initially we have to administrate the empirical antibiotic therapy. Empirical, which means that antibiotic therapy without the knowing the causes of organisms, with just at initially we are administrating to the patient. And we have to support the patients because these patients will have a dehydrations. In order to remove the toxic substances, the patients will urinate more compared to that of a normal patients. To support the patient's hydration, sufficient amount of the fluid and electrolyte should be given to the patients. And then incisions and the drainage and the extractions of the offending tooth has to be done. A swab culture and then has to be done to identify the exact microorganisms which is involved in the infection state, and then accordingly the identified organisms antibiotics should be administered to the patient. So what antibiotic should be given to the patients and how it has to be selected? Always the selection of antibiotic is depends whether the patient has to be treated as an outpatient or whether the patient has to be treated as inpatient, depending upon the severity and age of the patient. To treat the patient as outpatient, start with enough of penicillin, clindamycin, amoxiclavolate, it's augmentin, and dicloxacin, cephalexin, gentamicin. If the patient is known allergic to the penicillin, start with erythro, clinda, moxifloxacin, and metronidazole. Along with everything, metronidazole should be combined or it can be given alone. Inpatient, if the patient is asked to be admitted in the hospital and the patient is severely infected and then the swellings becomes more larger in the sizes and it obstruct the airway and the patient is diabetic patient and a age old patient, such a condition, administrate the patient. First admit the patient and administer clinda or ampicillin plus sulbactam or amoxiclavulinate. If they are allergic, start with an IV clinda and third generation cephalosporins, moxifloxacin, and metronidazole. So first, initially administered antibiotic supported therapy should be given to the patients and followed by that of a surgically incision and the drainages. So the most commonly used forceps for the drainage is a Lister forceps, and then Hilton's method is most commonly used method. So that the Ilton's methods of the drainage has to be done. The incision should be placed in the most dependent part in order to allow the drainage to be takes places under the influence of the gravity. Use a number 12 blade, place an incision and place an incision in that region. A number 11 blade has to be placed for the incision. So you place an incision along the most dependent part of the swelling. uh, the incision, in case of a Ludwig angina, the incision should be placed. Previously, they started using a cutthroat incision. One of the disadvantages of placing a cutthroat incision is that so it affected the aesthetic. So in order to avoid that, incision should be placed bilaterally submandibular region. The most important structure which is runs along the submandibular region is the marginal mandibular nerve. In order to prevent the damage to that of the marginal mandibular nerve, the incision should be placed at 1 to 2 centimeter below or 2 fingers below the margin of the mandibular border. So place the incision and then insert the Lister forceps. As I mentioned previously, the most commonly used forceps for the drainage. Insert is a Lister forceps. Insert the forceps in a closed manner. Open up the forceps inside that cavity and break down all the locules, drain the abscess, and remove the forceps in an opened manner in order to prevent the damage to the tougher structure. Since we are blindly doing that, in order to prevent the damage, the forceps has to be removed in an opened manner. Remove the forceps and allow the fluid which is collected inside the spaces to drain out, followed by place the drain and secure the drain. The drain has to be there in that region at least for the 48 hours until that the collections which is less than 25 mm. In case in emergency situation where the drain is not available, in such a situations, either a gauze or either a gloves can also be used. So there are certain principles for the incision and the drainage. Incise in a healthy skin and the mucosa, not in the area of maximum fluctuance. Aesthetically acceptable areas should be used for the incision to prevent the scar. Dependent position to encourage the drainage by gravity. Blunt dissection should be done. Close surgical stamp or finger through the deep tissue space. Place the drain and stabilize with a suture. Do not leave the drain for the longer period of the time because that drain itself will act as a source of infections. Followed by send the collected fluid for the cultures and then culture sensitivity test and antibiotic sensitivity either by aspirations or excisions of the tissues. And then a culture can be an aerobic, anaerobic mediums on antibiotic by the disc diffusion method. Once it has been the cultured, administrate the antibiotics. A specific antibiotic should be given to that of a patient. So what is the complications? First, we have done an ad. So along with that incision drainage, we have to remove that offending tooth which create these problem. Remove the tooth and place the suture over that region. What are the complications? The most commonly the edema of glottis, asphyxia, dysphagia, septicemia, mediastinitis, aspiration pneumonia. Even a death can occur due to the airway obstructions then from the sepsis. So these are all the complications of the Ludwig angina. To summarize, Ludwig angina is an infection which involves bilaterally submandibular, sublingual, submental spaces. So the classically, there are a cardinal signs for the diagnosis of Ludwig angina clinically is that. So the patients will have the cardinal, there are 4 types of the cardinal signs which is involved to identify the Ludwig angina, which includes bilateral involvement, gangrene. The infection can involve the connective tissue muscles, but not the glandular structures. It can spread through the facial spaces, but not through the lymphatic tissues. So that the dangerous sign immediately, if the patient present with the dyspnea, dysphagia, or any of these of dangerous sign, the immediate drainage has to be done to prevent and to preserve the life of the individual. Diagnosis, conventional, radiographically, and then clinically it has to be diagnosed. Management, these 7 steps has to be followed for the management of Ludwig angina in order to save the life of the individual. First, whenever the swelling is very large, if it obstructs the airway, the first and foremost should be an airway management, followed by that of incision and the drainage and the antibiotic administration. If not, initially administrate the patient and then admit the patient, administrate the empirical antibiotic along with that IV fluid as a supportive therapy, followed by the incision, drainage, extractions of the offending tooth, placement of the rubber drain, securing the rubber drain, and followed by the culture sensitivity and selective antibiotics to the patient. Thank you. Odontogenic keratocyst. It is first mentioned by Philipson in the year of 1956. According to the WHO, it's called as a benign, unicystic or multicystic, and interosseous tumor, which is a tumor which is developed inside the bone, which is of odontogenic origin, with the characteristic lining of parakeratine stratified squamous epithelium, and it has a potential for aggressive and infiltrative behavior. Previously, it was classified under the developmental odontogenic cyst of jaw by WHO in 1971 and 1992. OKC has been classified by WHO in 2005 as a KCOT due to its aggressive behavior and mutation in the gene. In 2017, WHO again reclassified OKC into the cystic category. There's a various terms and the classifications of OKC. Initially, it was called as a dental cyst by Hunter in 1774, and recently by the WHO in 2017, it was named as odontogenic keratocyst. Coming to the epidemiology and like clinically, it is most commonly it is among the all the jaw cysts, 7.8 percentages of the all the jaw cysts constitute, or 7.8 percentage is considered of OKC, and age is second to fourth decade of the life, and the male is most commonly affected, and the mostly of 83 percentage of the cyst will develops from the mandibular region, and predominantly it will present in the ramus of the mandible, and usually the swelling will be present with or without a pain. If it is infected, the pain will be present, and there is a discharge and the displacement of the teeth, occasionally the paresthesia if it is compresses the nerve, and expansions is very minimal in the initial state. Sometimes the buccal cortical plate will get expanded in case of a 30% in maxilla and 50% in case of mandible. And what are the possible syndromes which is associated with the trophin OKC, which includes nevoid basal cell carcinoma, Gordon-Gloss syndrome, Marfan syndrome, Ehlers-Danlos syndrome, Noonan syndrome, orofacial digital syndrome. And the radiographic features, well-defined unilocular and the multilocular radiolucency with the smooth margins, displacement of an adjacent tooth without resorption, and 40% of associated with that of impacted tooth. So this is a radiographic feature one can able to appreciate the unilocular radiolucency, which is presented within the medullary bone without any expansions of the cortex, and it causes a displacement of adjacent teeth without resorption, and it is associated with the 40% of it is associated with impacted tooth. Initially, it produces anteroposterior expansions of the jaw, so the expansion will not produce obvious swelling externally. Histopathologically, it appears to be a stratified squamous epithelium. It has a lack of retiridges, a well-defined basal layer, picket fence and tombstone appearance, a thin spinous cell layers, a satellite cyst is the most commonly and specifically and especially will be present for OKC. It's a satellite cells on the daughter cells. Because of that, the recurrence of the OKC is much more compared to that of the other cyst. What are the differential diagnoses? Histologically, it can be a myxoma, aminoblastoma, or central giant cell granuloma. Radiographically, a dentigerous cyst, residual cyst, later periodontal cyst, primordial cyst, unicystic aminoblastoma can resemble the features which is similar to that of the odontogenic keratocyst. What is the treatment modality? As I told, it's always for every pathological condition, the treatment will depend on age, size, locations, and soft tissue involvement. The treatment plan will be either enucleation or enucleations with chemical cauterizations, enucleation with peripheral osteectomy, enucleation with both the chemical cauterizations and the peripheral osteectomy, marsupializations, cystectomy or cystotomy and the resection. Enucleations, removal of the cyst along with the epithelial lining. Enucleation with the cornea solution is that, which is nothing but a chemical cauterization using a cornea solution which constitutes a glacial acetic acid, ferric chlorine, chloroform, absolute alcohol. Chloroform in it as a carcinogenic, so they removed it. So that recently it comes of glacial acetic acid, ferric chloride, and then absolute alcohol. It has to be prepared freshly prior to that of the procedure. Enucleation with the peripheral osteectomy, it is nothing but after the excision of the cyst, we have to remove the 1 to 2 mm of the bone in order to prevent the recurrence. And then Enucleation along with the chemical and then periphosphotomy can be done. Enucleations and the cryotherapy, which can be done with the help of the liquid nitrogen. So, or maybe a liquid nitrous oxide, which is nothing but freezing of the tissues and removes the tumor cells. Marsupilization with cystotomy, the marsupilization with cystectomy. Marsupilization is most commonly indicated in the patients of younger age group, and the patient who is having an cyst which is associated with impacted teeth, that teeth has to be preserved in order to prevent the fracture of the associated structure. Where the incision placed along the epithelial lining, it has to be so that the lining should be sutured to the oral mucosa and allowing the cyst to get decompressed to allow the cyst to drain and allow the cyst to reduce in the size. Either you can leave it as so the cyst will reduce with the formations of the deposition of collagen. Once it has been reduced in size, the epithelial lining has to be removed. Or else if it is a larger cyst and it's an aggressive cyst, it involves the entire mandible and causes a damage to the facial structure. In such a cases, we have to remove the particular part of the jaw, not the entire jaw, in order to prevent the recurrence. Since OKC, it's one of the highly recurrent tumor, there are certain reason for it. The epithelial lining of OKC is very thin. So whenever you try to remove the OKC, there are chances of rupture of epithelial lining, and then there is a spillages of the residual. From there, the cyst can again develop. Or else there is a presence of the multiple daughter cells which is presented inside the OKC. So that daughter cells, it's very difficult to remove it completely. So sometimes some daughter cell will remain back. So that daughter cells and the satellite cells will again develops and gives rises to the OKC. This is a pictorial representation how the enucleation has to be done. And as I told, enucleation has to be done along with an osteotomy, where the carnage solution, place the carnage solution, leave it for 5 minutes. After the 5 minutes, the depth of penetration will be 1.5 mm in cases of the bone. Followed by a re-rinse with saline, do a peripheral osteotomy, and the whole mucosa has to be removed. As I told, cryotherapy, you can use a liquid nitrogen, where immediate bone grafting can be done and the pathological fracture can be reduced. Marsupilizations, the procedure involves creation of window over the epithelial lining and the suture the lining to mucosa, convert the cyst into the pouch, decompress it, expose the cystic lining to the oral environment. So it's a pictorial representation of, it's a flow chart which represents how the cystectomy has to be done. First, do a marsupilization, pack the defect with iodoform gauze. Lateral cyst, later the cyst will get a reduced size with a deposition of the collagen. Enucleation has to be done once the cyst has been reduced in size. Send the tissue for biopsy in order to confirm whether it's a cyst or any other tumor. Resection, as I told, resection is nothing but the entire part of this jaw should be removed. Recurrence rate, it just depends upon the choices of the treatment. The recurrence rate will be 0% if we do a resection, and if it is like 38% if you do an enucleation with cryotherapy, with 30% if you do an enucleation alone, with 9% if you do an enucleation along with the chemical cauterization, with the 8% if you do an enucleation along with the carnage solutions and the peripheral osteotomy. And as I told, there are certain reasons for recurrences, since it's a thin epithelial lining, high level of proliferative activity, perforations of the bone, adherence to soft tissue, parakeratinized of layer, and growth of new OKC from daughter cyst. And one most important point is the diagnosis can be done with the help of the aspiration itself, where the aspirations of the fluid which shows the cheesy, dirty, white, creamy appearances with the protein contents of 5 gram per 100 ml. So with the help of that itself, that the diagnosis can be made in case of an OKC. And this is the one which is mentioned here, and then aspiration, and along with that, the radiographic features and then histopathologic features can also be used for it, for the diagnosis. And there are two types of an OKC. One is that orthokeratinized and the parakeratinized OKC, and among that, the treatment plan of the OKCs always depends upon the type of the OKC. Among which is a parakeratinized, is a more aggressive type, and it's always associated with the syndrome, and it has a palissaded columnar cell layer, whereas an orthokeratinized is less aggressive, it is associated with an indigenous cyst, and it has a flattened cell layer. So it's the causes of recurrences. The most important cause is the presence of daughter cells and the thin friable nature of epithelial lining and incomplete removal of cystic lining. Thank you.